Can I start?
Yes, sure. We are all ears.
Thank you so much. So what I'm going to provide this afternoon to you all is about the data science approach that we took for addressing the problem of the outbreak during the last 8 months in Iran. But I'm going to talk about it briefly about the COVID-19 pandemic and also clinical features of this pandemic among children in Iran, evaluating the test scale on the control of the pandemic in Iran, also hospital quality care for patients with COVID-19. And finally, we came to this conclusion, how we are related to the, communicable diseases such like COVID-19, as we know, as you introduced me as a chair of non-communicable disease research center. So we came to this conclusion, how these two pandemic, non-communicable disease pandemic and COVID-19 pandemic are, correlated, and how the syndemic of these two pandemic can be addressed and call to action also. So if you look at this, this is a, sorry, is there anyone wanted to say something, because I can hear some voices?
I will mute the microphones of everyone. So please, everyone, keep your microphones muted to not disturb the lecturer. I'm so sorry, Dr. Farzadfar. You can go
on. No problem, sure. Okay, if you look at this, you can see here the global, pandemic of the COVID across the countries, and we have the highest rate of the pandemic among countries like United States, Latin American countries, and also a few countries in the Europe also, including Spain and France. This is the COVID-19 deaths per million population, October 4th, 2020. So again, the highest rate of the mortality is about 1,000 per 1 million, which is very, very high in Peru. And then it comes to 700 in the United States, and so on, and it's about 400 or something close to this in Iran and other countries. And we have almost 7,000 deaths per day during this pandemic these days. This is the analysis of the COVID-19 registry system. As I mentioned before, this registration system comes from two different databases. We call it MCMC, and another is portal from Ministry of Health. They become combined, and duplicated will be removed. And this is the results of the data set that we have. As you can see here, the prevalence rate of COVID-19 among different provinces, with the highest rate of provinces like Khuzestan, Ardabil, Bushehr, also Semnan and Khorasan, North Khorasan, and most of those. Also, we have provinces with lowest rate like Kerman, Fars, Sistan Balochistan, and so on. So this is the prevalence rate based on the COVID positive rate, which means if someone is actually involved with COVID-19 and has not been tested and is asymptomatic or has some, very mild symptoms, are not included in this data. So this is all age mortality rate, and you can see here that we have mortality rate from 72 to more than to close to 600 per 1 million population, which is wide variety between the different provinces over here. So keep this in mind, and I will come back to these numbers later. The question is, many people, even people in Ministry of Health, are asking themselves the number that we are providing as a number of deaths for COVID-19 is it actually the correct number or not. We have done an analysis on the excess mortality to assess how the number that is reporting in the COVID-19 registry, how is different than the excess mortality that is provided by Idare Sabt Ahwal, which is vital, the registry for vital events, which has a bureau in Iran. So when you look at this, the first column shows you the COVID registry. The second column shows you the Bureau for Vital Events Registry, and the difference shows you how they are different. For example, we have for 3 months, first 3 months of the Iranian calendar year, more than 112,000 deaths. And if you look at the other years, I mean the years for 2019, for 2018, for 2017, the same period of the year, 3 months of the Farshad or Divesh and Khordad, if you look at the number of deaths is close to 92, 93, 91. So we conclude that there are excess mortality, which is higher than the number of COVID registry deaths, which is actually provided by the Ministry of Health. So how we can explain this differences between the deaths from the COVID registry and from the Bureau of Vital Events Registry? We came to this conclusion: those that have higher number of difference between these two registries could be due to underreporting by the universities of medical sciences, could be because of competing risk, because when someone has cardiovascular disease and because of COVID not getting the regular care, or COPD or other long-term condition diseases. So that could be one reason for increasing mortality rate because of that long-term condition like cardiovascular disease, not because of COVID-19. So competing risk is another reason for that, and also misclassification. Sometimes somebody passed away because of some specific type of COVID, which has a comorbidity with other diseases, and that case would be registered as that condition, long-term condition, not as a COVID. So this is a very complicated situation. We don't have data to address which one of those three conditions could be main reason for the difference between the registry, the deaths reported from the registry and deaths reported from the Bureau of Vital Events Registry. So this is a group one. You can see in the upper part of the graph, and in the lower part of the graph, we can see the provinces that reported number of deaths in the COVID registry much higher than that compared to what we have in the NOCR. So the reason could be because of these two actually possibility. One is competing risk due to risk factors reduction. For example, we know that the number of mortality due to road traffic injury reduced by 1,600 during these 8 months. So that would be another reason in the different direction, of course. Competing risk and also misclassification could be this. The way that we can address this is we go to the death registry, took 1,000 or 3,000 or 5,000 randomly, and do the verbal autopsy, check the reports from the people who actually got admitted in the hospital and then came up to the outcome of this. to evaluate which actually of those possibilities address most or majority of the their classification or competing risk or under reporting the differences between these registries. So this is one try that we have done, but still there are a lot of questions regarding why these numbers are not matched with the other part of the registry that we have in the Bureau of Vital Event Registry. So go back to part that I think you most interested in is the clinical features for children who got admitted in the hospital during the COVID-19 because of the COVID-19. So this is the age distribution. You can see different age groups. I will just talk about the total, total number. I'm not going to details of for each of these aspects. This rate, ventilator use rate, ICU admission rate, and sex ratio for each the specific age group. But you can see here, as much as we go from the younger age to the older age, the death rate will decrease, and this is the final number is 95 per 1,000, which means 10%, close to 10%, which is pretty much close to the adult number that we got in Iran, and much higher than we have seen in the previous presentation from Hong Kong and Wuhan. So if you go to the ventilator use rate per 1,000 is the same, close to 10%. ICU admission is 15%, which is much higher than actually adult, because we have the number of adults also. And the sex ratio is close to the adult, which is 30% higher among males compared to female. So if you go to the details, compare children which were previously healthy and compare them with the children that had one or two or more underlying comorbidities in different age groups. You can see here how the outcomes will change. For example, death mortality from 10% goes to the 70% in the children with the age lower than 6 months, from 6% to 20% in 6 months to 2 years, from 4% to 24% for 2 to 5 years, from 5% to 17% for the 5 to 12 years, and from 5% to 28% for 12 to 18 years. So you can see here the effect of the underlying comorbidities on the outcomes. The same story for ICU admission, the same story for ventilator requirements. If you go to the comorbidities to see what type of comorbidities, unfortunately, we didn't have details data. We just had the name of this is a problem of cardiovascular. We don't know what type of cardiovascular problem the children had, or diabetes, or chronic pulmonary diseases. It probably would be asthma or something, disabling neural disorders or malignancies. And please look at the odds ratio. And you can see here we have cardiovascular odds ratio 2.87, for diabetes 1 point close to 2, and for asthma close to 3, for disabling neural disorders close to 2, but it is not significant because the number of the people involved with this problem were very low, and malignancy close to 4, which is very high. I will show you how they are different, the odds ratios, compared to adult level in next slides. This is the clinical features, I mean the sign and symptoms. And if you look at those, the columns that I colored in red, fever, cough, headache, and sore throat, fatigue, dyspnea, nausea, and diarrhea are the different actually features based on the frequency, as you can see here, in the total hospital children, which gives us number of 1,600 children, and also those children with underlying comorbidity. And you can see there is no big difference between the frequency of the clinical features between the other children with no actually history of the underlying comorbidity and those that have one or two or more conditions, long-term conditions. So this is the features, the clinical features, which shows you the signs and symptoms. If you look at the last column about the type of treatment, we don't have data more than this. Actually, sorry for providing it like this, because this is exactly the data that we had. And we had a very hard time to categorize this data, as you can see here, because the box was open and everybody can write anything that they wanted. So we use the text mining system to categorize this in these four groups. Antibacterial drugs was like prescribed during the admission in the hospital, prescribed for 20% of those children. Hydroxychloroquine for 14%. We know the big results of the hydroxychloroquine in the text in the papers, which is not that much efficient. I'm not sure about this situation for children, but definitely for adults, they are not efficient. Antiviral drug close to 13%, and azithromycin to 7%. When we come and compare this with the children who had comorbidities, underlying comorbidities, you can see the numbers goes up significantly. 30% for antibacterial drugs, 18% for hydroxychloroquine, 17% for antiviral drug, and also azithromycin for 9%, which is pretty much high. Okay, this is the situation that we are facing during this pandemic, and the question is how we can control the pandemic. Many people in Ministry of Health and outside Ministry of Health in medical universities are actually disappointed to control the pandemic. But still, we believe, based on the data that we collected and we analyzed, we believe that still there are possibilities to control the pandemic in the way that we can have much less actually mortality for this problem. What we have done using the worldometer data, we create this graph and did a regression model to see how the number of tests can affect the pattern of the pandemic. What we have done was easy. We created we had a definition for control of the pandemic, which means the last 14 days, 14 days, we had a downward actually slope for pandemic in each country. And those that are green had this condition. And we also create a model, we put which country had controlled the pandemic based on this definition that we provided in the dependent variable, and added several covariates like GDP, like urbanization, like the years of schooling of the population, like sustainable development index, and also one additional variable, we call it positive rate, which means how many tests we have done, and from those performed tests, how many got positive. As much as this number is small, I mean the number of COVID tests from the whole performed test. The number of positive tests is in the numerator, and in the denominator we have all performed tests. So if the number goes up, means you are doing right. You are not doing right thing. You are doing much less than you needed for actually performing tests. As much as this goes up, goes down, means the number of performed tests is much higher than the positive detected cases, which means you are doing good. So we put this in the model, and it shows that this variable compared to other variables like GDP, like years of schooling, like sustainable development index, is much higher. The coefficient in the regression model. So we came up this as we consider this variable, which we call it positive rate, as a very important measure for controlling the pandemic. So we added Iran on this regression model, and we came to this conclusion that Iran now performing 25,000 tests per day, which is very low. And we did this analysis, and this coefficient gives us this indication. If you increase the number, the capacity of performed tests per day in the country by 5-fold, which means 175,000 tests per day, you can control the pandemic. And we are far away to do this. Is it possible to do it? We believe that it is possible. We have enough real-time PCR devices in the tons of research centers that we have, but now we are not using it in many, as I mentioned, research centers in the medical universities and science universities under administration of the Science Ministry of Higher Education. So based on those real-time PCR and based on the possibility to make considerable number of tests inside the country, we do believe that this is possible to get in this number. And if you get this number, 175,000 tests per day, your speed exceeding the speed of the spread of the virus. And this is possible to control the pandemic. Unfortunately, we are far away from this. So this is one of the analyses that we have done. And what additional actually survey that we have done was checking on the mortality rate, because the mortality, as you can see in the previous presentation, is like very low, 1.7, 1%, 1.4 in Hong Kong, in Wuhan for COVID-19, but in Iran is like 10%, which is very high. We know that as much as we're getting higher number of cases, we get higher number of mortality. It is understandable, but the problem is when we convert it to the rate, still this is very high. So for control of the pandemic, we do believe the test scale is the answer. For the control of the mortality, what is the problem? Let's see it. What we have done was we had data for 369 hospitals, and the number of admitted patients with COVID positive condition, we had the number of over there. And also we had the deaths inside within each hospital. We had the individual level data. So we simply divided number of deaths because of COVID to the number of admitted people because of COVID in the hospital. We call this observed mortality. So observed mortality could be different between the different hospitals because of different conditions during the during the admission time. So hospital like Imam Khomeini, like Masih Daneshvari, because they are very, they are referral hospital. They will get usually very bad patients with very bad conditions. So we had to adjust each patient with the other patients to be in terms of chronic conditions, in terms of severity of disease, in terms of age and sex, to be able to compare the quality of care within each hospital with other hospitals. So what we have done, we put that observed mortality in the dependent variable. We established a regression model, multi-level, and put the age, sex, malignancy, proportion of the patient, how many patients had malignancy, chronic pulmonary disease, diabetes, cardiovascular, kidney disease, liver disease, and we came to the severity of disease. Coma and dyspnea was indicators for severity. And we ran the regression, we got the data coefficient, and we fed number of each of those from hospitals, each of those covariates, and multiplied to the coefficient. What we got from that analysis, we call it expected mortality. If the conditions of the patient's severity, underlying mortality, age, and sex were exactly the same between Imam Khomeini Hospital and Masih Daneshvari Hospital, what would be the outcome? This is expected mortality. So we had observed mortality, expected mortality. We divided the observed mortality on the expected mortality. We name it Hospital Quality of Care Index. So hopefully I could explain it well. Here is the results. This is for Tehran University, some of those. For example, we removed from this analysis because the children mortality in different age groups were very highly different from the adults. So this is the results for adults. It is possible to do this for all hospitals from the actually for the age groups below 18, but it is for above 18 and for all hospitals except the children's hospital. So you can see if the number is higher than 1, for example, in Ziayan in Tehran, they have 2.5-fold mortality than we are expecting of them to have. So, which means the quality of care in Ziayan hospital is not that much good. But if you go to the Bahalu, the situation is reversed. There's below 1, which is pretty much better situation in terms of quality of care, which is directly correlated to the mortality. So this is the number of people admitted in the hospitals. For example, if you look at the Imam Khomeini Hospital here, and you look at the number of patients admitted to in Imam Khomeini Hospital, this numbers is for end of the July. It's not for recent numbers. So we have it. We have to update it, and we plan to do this. This is for Shahid Beheshti University, which is one of the universities established in Tehran, the mega city Tehran. We have 3 major, actually, medical universities over here: Iran, Shahid Beheshti, and Tehran. And these are the teaching hospitals. And you will look at this again. You can see, for example, Masih Daneshvari is one of the hospitals with a better quality of care for COVID. And look at this number, for massive دانشوری, which is pretty much high. So they have done a wonderful job, I think. Again, this is the way that we analyze it. You can add covariates, you can get somehow different, but we have done several sensitivity analyses and the results are pretty much the same. This is for Iran University of Medical Science. And you can see different hospitals and the quality of care. And this is other hospitals in Tehran, including public hospitals and private hospitals. And you can see here, for example, Madain is one of those best, and Baqiyatullah is one of those good hospitals, but the other hospitals in above, you can see it, and they have different quality index. And these are the numbers people admitted over there. So when we have done this for all country, we ask how many people have utilized their services from the hospitals, how many patients of COVID-19 have utilized their services from the hospitals in each university, from the hospitals that had a good quality. And you can see here, 0%, 0 to 20%, and so on until 100%. And you can see, as much as you can see, the green color means they have good, higher number of people who are receiving high quality care from the hospitals. So this is one of the analyses. Maybe some of you have some suggestion to improve the analysis. We would be more than happy to do this. We have done this in IHME, Institute for Health Metrics, when I was there. I was working over there. For cardiovascular disease, to estimate the quality of care across the whole hospitals in the United States. And I use that model for COVID situation. So this is the situation. And the other question was how much these two pandemic of non-communicable disease and COVID-19 are correlated. What we have done was to estimate the odds ratio for each long-term condition. And here is the result. For malignancy, the red line goes for children and the blue line goes for adults. And you can see here the odds, different odds. It's actually the uncertainty line for odds for children is very high because the number of children compared to adults is very, very low. So you can see here the different odds. We use these different odds to, I will explain this one after this slide. We use that odds ratio to estimate the population attributable fraction for each condition. Cardiovascular disease is 14% in adult. This is for adult. Chronic pulmonary disease, 5%. Diabetes mellitus, 8%. Cancer, 2%. Chronic liver condition, 1%. Chronic kidney disease, 3%. And if you do this, we come to this conclusion that 33% of mortality because of COVID could be attributed to non-communicable disease. So there is a very, very big link between non-communicable disease and COVID-19. And we have to do a lot to make sure that we understand all aspects of the interaction between these two epidemics. We call it syndemic. Two epidemics with the common ground roots. So we actually came to this conclusion for that. I go back to the previous slide. This is one of the analyses that we did with association rule mining. and ask ourselves, what would be the probability of this if each of these conditions, including comorbidities or signs and symptoms, do exist and among the patients, what would be the probability of this? For example, chronic pulmonary disease, if we have this, we have a probability of this higher than 25%. If we have diabetes, fever, and dyspnea, it's like 23%. If we have diabetes and dyspnea, it's a little bit reduced, and it's because we don't have fever. Cardiovascular and dyspnea, the number goes like 22%. Cardiovascular, fever, and dyspnea, and so on. And it's interesting results from this. If you look at the fourth one, which is cardiovascular and dyspnea, the probability of this is close to the 22%. If you go to 3 row lower, which is cardiovascular, dyspnea, and cough, the same condition and plus cough, the probability of this goes down by 1% or 2%, which means cough somehow is protective, or the existing cough shows better outcome. Why it is so could be because of the cough is somehow a mechanism to exclude the viral load, or cough could be simply just a sign of well-being of the patient. The patient who has a cough has a better clinical condition rather than the patient who has no cough. So this is another approach for analysis of the situation. So call to action, we need to increase the test capacity to control this pandemic. Otherwise, we have to be witness of tons of thousands of mortality inside the country. So if we want to change the situation, we have to do, something like increasing the capacity by 7-fold. Somehow for, people working in ministry office is very, very high, and maybe it looks impossible, but to control the pandemic, you have to do things that looks impossible. Otherwise, we have to be witness with tons of mortalities higher than what we have seen from now. The second message is hospital quality is crucial. People are dying in our hospital in different way, in different level of the quality. So why we don't easily just go to the hospitals with better quality and see what they have done? It is not the quality that we are actually compared with the quality of the hospitals in the United States or UK or France. It's just simply we divided hospitals in 2 groups, low quality and high quality, and compare high quality inside Iran to the low quality inside Iran. So it means this is absolutely possible for us to go to the hospitals and change the quality of care over there. Something's wrong in hospitals. And data show us this problem, and we have to address it. And we have to think how we can address it. This is the problem, definitely. And for example, in Spain, we have very high level of prevalence of COVID-19, but we don't have that much mortality. If we have even high level of the pandemic, but we could control the mortality, definitely we would be successful to somehow manage the problem. Otherwise, I don't know what happens. The third call to action is that 33% of deaths due to COVID-19 are attributable to non-communicable disease. Don't forget to provide care to patients with non-communicable disease. If you do this, you will help reducing the mortality due to COVID-19. Please do so. Please make sure that the utilization care for children who have a long-term condition doesn't, affected by COVID-19 pandemic. I know it is very hard. I know the clinician have no actually authority to bring patients for receiving the utilization, but please think about it, how you can make sure that the children with long-term condition will receive their care completely. Otherwise, if they got contracted with COVID-19, the mortality is much higher than those who has a control on the long-term condition. The fourth one, the call to action is odds ratio of comorbidities suggests team approach to control mortality in hospitals. This is not the infectious specialist job. This is not the ICU man specialist job. It's job of the team. Cardiologists, gastroenterologists, nephrologists, any other specialists, when one kid comes to the hospital with 2 or 3 conditions, you have to create a team to address the problem. Otherwise, please don't accept better condition than what I have shown to you during this situation. And the last one is evaluating the death registration system. Because as I show you, there are the dots on the numbers, and could be because of the underreporting, could be because of the misclassification, and we have to address these problems. Hope these messages can be spread to the actually health professional community and then policymakers, and we can see some changes in the pattern of the control of the pandemic. Thank you so much, and sorry for taking your turn.
Thank you very much, Dr. Farzadfar. It was a great presentation as always. We are so proud to have you with us in Tehran, and we all wish you health and thanks again. Can you just give us some answers for the questions, but very quickly, because our next presenter is also available right now, and she's very busy in her hospital. So the question, the main question is, what is your prediction of the end of the pandemic? Can you predict when will be this pandemic ended?
You're always asking a hard question, Dr. Roy. Actually, we didn't do any analysis on what would happen if we don't do anything about the pandemic. Well, what now we are doing in terms of the major measures of the control of pandemic, like washing hands, wearing masks, and actually the third one, washing hands, wearing masks, and distancing, social distancing. If we could convince population to do this, which we are now far away from this, like 40% away, 60% based on some analysis are respecting these guidelines. And if we do the, increasing the capacity of test is very important. And if we want to have one direct intervention regarding from Ministry of Health and from medical universities to control the problem, is test and tracing. If we do this and that, and also do some interventions for the improving the quality of care, we will come out with this pandemic with the, something like pretty much good outcome. I'm not going to provide you the numbers. I have some in mind, but I think it is not wise action to provide numbers. But if we don't do this, you have to multiply the numbers of mortality by 10 or 20 outcomes. This is very, very dangerous situation, and we have to do something. Please, if you have voice in medical universities, if you have voice in Ministry of Health, please advocate to start testing, performing tests, increasing the capacity, and do something about the quality of care in the hospitals.
Thank you very much, Dr. Farzadfar.
Yes.
Just another quick question. Can I ask you when will be the data for the children hospitals available to everybody? Can you just give us a time?
Actually, as you know, Dr. Abai, the research center is non-communicable. This is a research center, so we don't have budget line for doing the analysis. These are based on our social responsibility that we feel we are doing this, and we have a very limited numbers of experts to do this analysis. So I provided the new numbers, the database, asking my colleagues to do the analysis. The first step is cleaning the data, and the second step is verifying the numbers, and finally doing the analysis. Hopefully, we can come with this conclusion between the hospitals, children hospitals, and comparing the quality of care between those in 1 month from now.
And the last question. I know we have very talented and very good friends of ours in this session from the United States. I just want to ask you, do you have any comparison between the data from Iran and also from the United States, especially regarding the amount of tests that they are doing by a daily basis? And can we just do a comparison between the United States and Iran?
I'm not sure about the exact number, but I know the one in the beginning of the pandemic. The United States has almost fourfold more population compared to our population, close to 320 million population in the United States. But in the first days, they had more than 200,000 tests per day. And now it is close to 1 million, And you can see that every day they are actually identifying more than 100,000 individuals COVID positive tests. And they have a tracing system also. So they are not good in the tracing, unfortunately, but they are good in the testing. Still, they need to increase the number. But when you compare it with this, United States wouldn't be best country to compare because they are still in the shortage of the number of tests. If you go for example, some country like United Kingdom or country like New Zealand or Bruxelles, many other countries with a very, very high rate, and also South Korea. The control of the pandemic in the South Korea was only because of increasing capacity tests. And if it goes to the level that the speed of tracing gets over the speed of spreading the virus, you are in the control. Otherwise, the virus will control you.
Thank you very much, dear Dr. Farzadfar. You are always a great help for us and for all the medical staffs here. I wish you a complete health as soon as possible, and thank you very much.
Thank you so much. It was a great pleasure, Dr. Ali. Bye.
Thank you. So Mariam, can you please introduce our next lecturer?
Yes, of course. So thanks again, Dr. Farzadfar, for this amazing and mind-blowing data and your great lecture. Thank you so much for joining us and also sharing your time. So our next lecturer is going to be Dr. Sindhura Bandi. Dr. Bandi, can you hear me? Do you have my voice, Dr. Bandi? Yeah, okay, I see your head nod. Okay, so
Dear Dr. Bandi, thanks a
yes.
lot for your patience. I know you are very busy in your
Yes.
hospital, and thanks again from all of our audiences on behalf of all our audiences and the team here. Thank you very much.
So before you start, I'm just going to give you a brief introduction for everyone who's joining us and who doesn't know you. So Dr. Sindhura Bandi is an allergist and immunologist in Chicago, Illinois, and is affiliated with multiple hospitals in the area, including Rush University Medical Center, Oak Park Hospital, and John Stroger Cook County. Throughout her career, Dr. Bandi has been involved in scientific scholarly activity, including patient-centered outcomes research in the area of asthma with the Chicago Area Patient-Centered Outcomes Research Center Network. Dr. Bandi is a fellow of the American Academy of Allergy, Asthma, and Immunology, serving as the vice chair of the Quality, Adherence, and Outcomes Committee Hospital. So thank you, Dr. Bandi, for joining us and for sharing your time with us. We are again sorry for the delay that we had, and we are more than honored to have you, and we are ready with you whenever you are. So I'm going to make you a co-host now so that you can start sharing your slides. I see that you've done that before me. Okay.
We're getting
Thank
very
you.
used to this virtual platform these days. So
Yes.
thank you very much for having me, and look forward to sharing with you all some of our experiences here regarding multisystem inflammatory syndrome in children. So I know there were a few questions regarding that in the chat as well. And so thank you very much for the kind introduction as well. So a little bit about this disorder. So it was first described back in March of 2020 in Italy and the UK, which makes sense because this is when we, a few weeks out of the peak in Europe. And a small number of children during that time were admitted with signs and symptoms that were similar to Kawasaki disease. But interestingly, they also appeared to have a lot of GI symptoms, abdominal pain, diarrhea, vomiting, and most of these patients were negative for SARS-CoV-2 by PCR. Since that time, we've had 570 reported cases of this multisystem inflammatory syndrome in children in the US per our CDC, and over 1,000 cases reported worldwide. So a little bit about the nomenclature. So it's known as different entities across the world, but really the clinical diagnosis is the same. So in the UK, the Royal College of Pediatrics first reported this in April of this year, and they called it PIMS, Pediatric Inflammatory Multisystem Syndrome. And the diagnostic criteria involves a child who presents with a persistent fever, evidence of inflammation by a variety of different laboratory markers, including neutrophilia, CRP, lymphopenia, and also evidence of either single or multi-organ dysfunction. These children may fulfill some of the criteria of Kawasaki disease, so I'll get into that in a little bit. In addition, this is a diagnosis of exclusion, so there must be an exclusion of other microbial causes, particularly staphylococcal, streptococcal shock syndromes, because the clinical presentation is very similar. The PCR testing for SARS-CoV-2 may be positive or negative in these individuals. Now, the Centers for Disease Control here in the United States has termed it multisystem inflammatory syndrome in children. And this is any individual under 21 years of age who presents with fever, laboratory evidence of inflammation, and evidence of clinically severe illness and multisystem organ involvement. And I'll go into the organs that can be involved, but really any organ may be involved in these individuals. Again, this is a diagnosis of exclusion, and they also include that these patients might have a positive or recent SARS-CoV-2 infection, a positive serology or antigen test, meaning a positive IgG antibody, or this epidemiologic link, so the COVID-19 exposure within 4 weeks prior to the onset of symptoms. So that's really key in sort of determining whether it may be related to this. I think someone might have used their writing tool to scribble on this screen. Some additional considerations may fulfill full or partial criteria for Kawasaki, but should be reported if they meet the case definition of MISC. Let me stop sharing and share again and see if we can get that to come off.
Sorry, Dr. Bandi, for this.
Oh,
I don't know who's doing that.
No problem. Okay. And so you must consider MISC in any pediatric death if there's evidence of SARS-CoV-2 infection as well. So a little bit about Kawasaki. You all, I'm sure, are very familiar in evaluating and treating this condition, but the diagnostic criteria involves a fever of at least 5 days without any other explanation and at least 4 of the 5 following criteria. So they may have a bilateral bulbar conjunctival injection, which is limbic sparing. They may have oral mucosal membrane changes, such as injected or fissured lips, injected pharynx, strawberry tongue. There will be peripheral extremity changes, including erythema of the palms and soles, periungual desquamation. They may develop a polymorphous rash, and then cervical lymphadenopathy may be possible. If they have less than 4 of this criteria, but they do have this prolonged fever without any other diagnosis, then that may be considered what we call atypical or incomplete Kawasaki. So here is kind of a schematic from the Kawasaki Foundation pointing to some of these clinical signs that we see: the conjunctivitis, the strawberry tongue, the erythema of the palms and soles, polymorphous rash, fissured lips, which all of you, I'm sure, are very experienced in seeing. So in these first European cases back in March, the majority of the children ranged from 7 to 9 years of age, so very small window of this age range. And there were about 8 to 17 children in these initial reports. And a lot of them had these KD-like symptoms, but they all had GI symptoms as well. And a vast majority of them presented in shock, particularly with cardiac involvement, either myocarditis or coronary artery aneurysm. And most of these kiddos were PCR negative, but IgG positive. In looking at the first European cases and the children who were very sick, who were admitted to the pediatric ICU, there was a case series looking at 35 children from France and Switzerland. And again, the median age of admission was around 10 years of age, although it ranged from 2 to 16 years of age. Again, GI symptoms were common. All the children had fever, and all of them were either admitted to the ICU right away or within that first 24 hours of hospitalization. This is really important to note too, because this is what we see in these children, is that there's a very quick and dramatic escalation of their clinical symptoms. The majority presented in cardiogenic shock with reduced EF, and 10 of these patients actually required ECMO. 88% of the patients were either PCR positive or antibody positive, which goes with sort of that link with the COVID. And in terms of therapy, which I'll talk to you a little bit more in detail, the majority of patients received IVIG, which is similar to how we treat KD. About half the patients received steroids, and a few of the patients received anakinra. Now, this was at the very beginning of this recognition of this disorder that these treatments were being administered. Since then, we've established some treatment algorithms in how to manage these patients. So here at Rush, in terms of, we've had quite a few cases, but in terms of the patients who have been acutely ill, we've had about 4 or 5 children. And all of them have multisystem involvement. fevers, GI symptoms, seizures, cardiogenic shock, and respiratory failure. All of them received immunomodulator treatment. So this was a question on the chat box earlier in terms of methylprednisone and whether it's helpful. I'll talk to you guys a little bit about it, but all of these patients received methylprednisolone and IVIG, and 2 of them received anakinra therapy. 3 of the 4 have subsequently been discharged and are at home recovering well. 1 patient is still in the hospital and he is going to be discharged to inpatient rehabilitation. So we talk about how this might be related to KD, Kawasaki, but we need to know that MIS-C is a separate entity from KD. The children are older than those that we usually see in typical KD. They have a similar presentation, more like a septic shock syndrome, which is why it's important to rule out these toxic shock syndromes. They have elevated inflammatory markers much higher than what we see in patients with KD. Their IL-6, IL-10, interferon gamma, all these measures of Th1-mediated inflammation are elevated. They also have significant thrombocytopenia, anemia, low albumin, have high D-dimers, and lymphopenia. We see troponin leak in these children a lot, and about 1/3 of them can have LV dysfunction as well as myocarditis. We don't see that same degree of myocarditis in KD patients. A lot of them also will have a persistent fever after the end of IVIG. We know that we can redose IVIG after 24 to 36 hours in these patients with KD, but a lot of them will continue to have fever, which is why sometimes other immunomodulatory therapy is required. So in summary, MIS-C and KD are unrelated to SARS-CoV-2 infections, may share some overlapping clinical features, which we discussed. But there are clinical features that make MIS-C more likely in the diagnostic criteria. There's also an increased incidence of MIS-C in patients with African, Afro-Caribbean, and possibly Hispanic descent, but a lower incidence than what we see in KD of East Asian descent. Patients with MIS-C have a broader age range, have more prominent GI and neurologic symptoms, frequently present in shock, and are more likely to display cardiac dysfunction, including ventricular dysfunction. At presentation, patients with MIS-C tend to have more thrombocytopenia, lower lymphocyte counts, higher CRP levels, and we do know that these patients can develop coronary artery aneurysms, but they also have a variety of other cardiac manifestations. So here is a kind of a summary looking at the different groups, kind of our classic MIS-C, acute COVID, and other conditions like KD. So as we can see, the age range is a little bit higher in MIS-C or acute COVID. And you're going to see a higher rate of abdominal pain as well as shock in those individuals. So why does MIS-C happen? What's the proposed mechanism? This most likely represents a post-viral immune response, and this typically occurs about a month post-peak COVID-19 infections in the area. So that's why we were seeing the first cases out of Italy, because that's where we were seeing the first peaks. And so I'm sure it's a similar experience for all of you too in Tehran and Iran, based on where your peaks landed. The majority of patients with SARS-CoV-2 will, with this condition will have IgG positivity, but some may still have PCR positivity. And as some of the other talks described, you know, the PCR can remain positive for prolonged periods of time in these children. And whether that represents acute infection remains to be determined. So this is a schematic looking in adults, how acute COVID sort of progresses. Initially, they'll have the infection, have a viral response phase. Then there might be some degree of pulmonary involvement. So we end up seeing, you know, respiratory involvement, hypoxia, need for oxygen. And then later on in the kind of convalescent stage, we are seeing this host inflammatory response in adult patients. And so they're, you know, requiring tocilizumab, IL-6 blockers to kind of block this inflammatory response. So this is all happening very acutely during that initial infection response phase. But in children, we're seeing this kind of maybe present with no infections at all or symptoms at the onset of the virus exposure, and then later on, 4 to 6 weeks later, having this inflammatory response. So we know that SARS-CoV-2 replicates in various cell types and suppresses early type 1 interferon responses. And so without that robust innate immune response, there ends up being cell death and pro-inflammatory cytokines released. And this viral replication then leads to tissue damage and recruitment of both innate and adaptive immune cells, resulting in this dysregulated immune response. So perhaps in children, this response seems to be more delayed than what we're seeing in adults with acute COVID infections. There's other possible mechanisms that have been proposed, and there's a lot of study that needs to go into sort of why this is happening in children and why so delayed, particularly if they don't even exhibit any symptoms of COVID to begin with. There might be a degree of antibody-dependent enhancement, and that might be why that development of the IgG antibody is so important in these children. In addition, there's been some reports that this anti-spike IgG to COVID can cause severe acute lung injury by skewing macrophages responses. So perhaps these children are now having this robust innate immune response, but it's skewed. There can be immune complex formation and activation of neutrophils, platelets to trigger this inflammatory response. In addition, maybe re-exposure is triggering this HLH-like picture in these children. There might be a degree of molecular mimicry promoting an immune response. And then in addition, we are learning now that it's not just the antibody response that's important in COVID. This is really important when we're talking about vaccine development, that these T cells and the T cell immunity is really playing a role in COVID response as well. So perhaps there's an effect on these regulatory T cells. There seems to be less regulatory T cells in these children, CD25 T cells, and they make less IL-10 then, and so they're not able to regulate the immune response. So now we'll get into a little bit about the guidelines for the evaluation and treatment. So there are many clinical guidelines that have been published worldwide. Different hospitals have different algorithms or clinical guidelines regarding the treatment. So what I base sort of these recommendations on is what has been developed by the American College of Rheumatology, but a lot of this is what is being implemented worldwide by other hospital systems and other international organizations. So the vast majority of children with COVID-19 will have mild symptoms and excellent outcomes. We know that to be the case. So we need to be vigilant of those kids who might not have those good outcomes. MIS-C is still rare, and it's still epidemiologically associated with SARS-CoV-2 infections. That diagnosis of exclusion and that epidemiologic link is important in assessing this condition. So we have to evaluate for other infectious etiologies when children are coming in with a presentation similar to MIS-C. And they may require additional diagnostic testing, even hospitalization, so that we can sort of assess these symptoms. We must consider admission in these patients if there's evidence of abnormal vital signs like tachycardia, tachypnea, respiratory distress, neurologic deficits, or change in mental status, even if it's mild, because this condition progresses so quickly. If there's any evidence of even mild renal or hepatic injury, we should consider admission. If there's elevated inflammatory markers, particularly CRP, or if they have an abnormal EKG, BNP, or troponin. So here's an algorithm basically looking at some clinical guidance. And again, many hospital systems have implemented similar clinical pathways. So does the patient have a fever? Do they have a link to SARS-CoV-2? And do they have either a rash, GI symptoms, edema of the hands, mucosal changes, conjunctivitis, neurologic symptoms? So a lot of these KD-like symptoms, but also other symptoms like neurologic symptoms, respiratory symptoms, GI symptoms can come into play. And that's when we sort of determine whether or not we want to start this investigation pathway for MIS-C. What's important is that we need to make sure that we are being vigilant about lab monitoring. So kind of doing these tier 1 and tier 2 labs, first starting out with the CBC, CMP, inflammatory markers, looking for evidence of thrombocytopenia, anemia, renal or hepatic involvement, elevated inflammatory markers, and also doing this SARS-CoV-2 PCR and other serologies. If there's evidence of that, then we might want to delve a little bit more into our diagnostic pathway, particularly looking at troponin, procalcitonin, D-dimer levels. All of that has been linked to this inflammation that we see in MISC. So admission requires consultation of a multidisciplinary team. So every pediatric intensivist, pediatrician, subspecialist is really important in the management of these patients. And so that approach is really important. So particularly when we talk about these cardiac considerations, patients with MISC and abnormal BNPs or troponin at diagnosis should really be carefully monitored. We should be checking these laboratory parameters frequently and trended over time. And the EKG should be performed a minimum of every 48 hours when admitted, if not more frequently. Echocardiogram should be conducted at diagnosis and during clinical follow-up and should be repeated at a minimum of 7 to 14 days and then 4 to 6 weeks after a presentation. We don't know yet what the long-term follow-up of these children should be. We're just now starting to see development of more permanent cardiomyopathy or LV dysfunction, arrhythmias. And so that's where, this long-term follow-up will be really important as we're seeing more children diagnosed with this condition. Patients obviously with LV dysfunction or any evidence of coronary artery aneurysms need more frequent echoes. They may require cardiac MRI or cardiac CT as well, depending on their clinical presentations. Now, we spoke a little bit about this immunomodulator treatment and how we should determine our treatment for these children. So if a patient is under investigation for MISC and shows evidence of life-threatening manifestations or organ dysfunction, we may need to start this immunomodulator treatment before the full diagnostic evaluation can be completed. And this is common to other conditions as well when a patient is admitted to the pediatric unit. So a stepwise progression of this therapy should be used to treat MISC. So IVIG and or glucocorticoids is considered the first tier, and that's similar to how we treat our KD patients as well. We can consider high-dose IVIG, and looking at their cardiac status is really important. Well, I mean, if they're in shock, we really need to maintain their cardiac function and fluid status as well. How does IVIG work? So it works by neutralizing either a toxin or superantigen. So if there is a superantigen mechanism behind this condition, it helps to actually block that. It also neutralizes these pro-inflammatory cytokines, which we know are very prominent in this disorder. It blocks Fc receptors on macrophages to prevent the skewing of that macrophage response. It induces tolerogenic dendritic cells as well as expression of IL-10 and regulatory T cells to help mediate the immune response. Children with severe respiratory symptoms due to COVID should be considered for immunomodulator therapy. So if they have evidence of ARDS, shock, elevated D-dimers, LDH, IL-6, CRP, then they should definitely be considered for initiation of this therapy. So we talked about glucocorticoids. So low to moderate dose glucocorticoids may be considered for treatment with or without IVIG therapy. If they are in shock, similar to any other pediatric patient in shock, high dose IV pulse glucocorticoids could be considered. We mentioned anakinra. So anakinra is an IL-1 receptor antagonist. And what we find is that in the vasculitis that we see in KD, that IL-1 is implicated in that. In addition, in HLH or MAS, we also see that blocking IL-1 can be helpful. And so that's where we started using IL-1 receptor antagonists in these children to kind of block this immune response. And the good news is it's very well tolerated. The half-life is very short and it rarely causes opportunistic infections. So it's a good addition in terms of immunomodulator therapy that's going to be low risk to the child. And we have found that it's beneficial in these patients. So generally we will give greater than 4 mg per kg per day, either IV or sub-Q, in patients who may be refractory to IVIG and or glucocorticoids. Serial laboratory testing and cardiac assessment should be done in monitoring the response to therapy as well as tapering of these therapies, because they need to be tapered over a couple-week period. There's been some new literature that's shown that initiation of anakinra before invasive ventilation may be beneficial in preventing the progression of respiratory distress or ARDS in these children. So that's been some new literature that's been very hopeful as well. Children with COVID-19 treated with anakinra should be monitored in terms of their LFTs as well. Now, tocilizumab is more commonly used in adults. It's an IL-6 blocker. And so we use this more in adults who have active COVID and then develop cytokine storm. So it's not used as commonly in children with MIS-C, but it is part of the diagnostic treatment pathway. These patients are at higher risk of developing bacterial and fungal infections, so they need to be monitored closely for that. Anticoagulation is very important in MIS-C patients because they're much more likely to develop thrombosis and other coagulation effects. So, similar to KD, low-dose aspirin may be utilized. However, there's I'm not a hematologist by trade, so definitely this is something that the hematologists monitor. They check the Z-score and consider therapeutic anticoagulation with enoxaparin or warfarin, depending on their risk for development of thrombosis. Patients with MIS-C who have documented thrombosis and a low EF should get enoxaparin, and then they should be continued on that after discharge from the hospital. And again, we're learning more about some of these outcomes and how long these patients need to be treated for. So in summary, early recognition, evaluation, and treatment for MIS-C is really important. We don't fully understand the immune mechanisms behind it, but it does differ from COVID-19 in adults and cytokine storm, and it does differ from KD. But there are clinical and laboratory features which are similar to other inflammatory processes in children. A multidisciplinary approach is really key in managing these patients and making sure that they have the best outcomes. So thank you.
Thank you, Dr. Bandi, for your amazing lecture and for your great presentation. And also, again, thank you for joining us. So one of my friends had a sentence he wanted to share with you. So, Aylar.
Hi, greetings, dear Dr. Bandi. It's so nice to have the chance to see you again, even online after the recording sessions we have you together. I just want to say something that I'm hope to say it correct. आपके पास भी होना एक बड़ा सामान है निमंत्रण को स्वीकार करने के लिए धन्यवाद.
That was very good. That was very good. Well, thank you.
I hope to see you in person one day in Iran.
Yes, we would love that. I will come with Dr. Bakhmadov.
Thanks a lot. Your presentation was awesome. Thanks again.
Thank you. Thank you.
Yes. Okay. So, Dr. Bandi, I see a few questions in the chat section. If you don't mind, I ask them from you. So, there was a question way before about your experience with methylprednisolone pulse in MIS-C. So, can you share your experience with that?
Yes. So what we're finding is that it does appear to be beneficial. So the initial guidelines said that you could start with IVIG, and then if you need to redose the IVIG, consider addition of methylprednisolone during that time. However, studies have found that actually using them both in conjunction appears to be beneficial in these patients.
Okay, so we had another question about the incidence of coronary involvement. Is it the same in KD patients and also in MISC?
So we're just learning about this. What we do know is that in patients with MISC, there's a much higher incidence of LV dysfunction, arrhythmias, and myocarditis. In terms of the coronary artery aneurysms, we do find that children with MISC can develop coronary artery aneurysms similar to KD, but the actual incidence when compared head to head hasn't been well established yet.
Mm-hmm. Okay, so thank you. So the next question I'm seeing is about the role of serum ferritin and also IL-6 in diagnosis of MISC.
So they're both very important markers to sort of create a complete picture of whether or not this patient who presents has evidence of hyperinflammation. So we do utilize the ferritin and the IL-6 as two of those sort of markers. We also use them to help us determine response to therapy in conjunction with BNP, D-dimer, looking at the lymphocyte counts and the neutrophil counts, and the procalcitonin. So all of those can be helpful. In patients who are very sick, we might do a more comprehensive cytokine profile, which includes other markers like, interferon gamma, IL-1, IL-2. So that can give us a more complete picture as well.
Mm-hmm. Okay, thank you. So, Dr. Yarowinski, our next lecturer also had a question about the is that, do you know if the survivors of MISC are at risk of recurrence of their symptoms?
Yeah, so thus far, there hasn't been any good data on sort of the long-term effects, because we're just seeing this starting back in, March is our first cases in Italy. Thus far, there has not been any evidence of recurrence of the symptoms, but there has been evidence of prolonged cardiomyopathy, LV dysfunction, need for more long-term anticoagulation due to risk of thrombosis. So those are some of the things that we're seeing right now, as well as maybe some evidence of cognitive impairment. And that's what we're actually seeing on the adult side in patients with acute COVID too, as we're monitoring some of these long-term things. But there's been no reports yet of any recurrence of specifically MISC.
Mm-hmm. Thank you. The next question that I'm saying is about the use of remdesivir in treatment of these patients, the PCR positive patients, even in the absence of respiratory symptoms. So do you have any idea about that?
Yeah, thus far, remdesivir has not been recommended in patients who may present with an MISC-like presentation, even if their PCR is positive.
Mm-hmm. So I'm sorry about the rapidity of asking the question because we're short in time, and thank you for your precise and also short answers. So the next question I'm saying is about sometimes or almost MISC is life-threatening event, and we don't have enough time for exclusion of other causes such as bacterial infection. What is your opinion for management of children in these situations? Do you recommend treatment before confirmation of MISC?
Yes, so the recommendation is if the patient is acutely ill and MISC is on the differential, but we have not been able to yet rule out other etiologies, we still recommend going ahead and proceeding with immunomodulator therapy and going down that diagnostic pathway of getting all these tests. That's really important to note because we have to think about the epidemiologic link. And right now, COVID is everywhere. We're all in it. So it's okay to assume it's MISC until otherwise. So yes, we often do go down that pathway.
Thank you. So the other question, actually there are two questions that they have the same theme to them. So one of them is asking about the D-dimer and the need for coagulation, and also another one about enoxaparin in these patients. So what's your opinion about these?
Yes, so I'm not a hematologist, so definitely we always get our hematologists on board to make sure that they're appropriately anticoagulating these children. They are at high risk. So what they generally do is they'll calculate the Z-score of the child based on their D-dimer and other factors, and we'll recommend treatment for enoxaparin. And then sometimes they might need more prolonged enoxaparin therapy after discharge.
Mm-hmm. And the last question that I'm saying is about your experience about using anti-TNF like infliximab in treatment of children with severe MIS-C.
Yeah, so it is part of actually the treatment algorithm. So tocilizumab, infliximab, rituximab are actually all included in those. We personally have not used it at our institution because all the patients have recovered with treatment with either methylprednisolone, IVIG, or anakinra. And actually, if you look at the worldwide studies, it's not utilized as frequently as the other modalities.
Mm-hmm. Okay, so thank you, Dr. Bandi. I don't see any more questions. Again, thank you for your patience and thank you for joining us, sharing your time, knowledge, and expertise with us. It was really an honor to have you with us again today. And we hope to see you one day in Iran to serve you and to host you, and you will be more than welcomed here. So, Dr. Aghaei, if you want to add anything.
I also want to thank you for your patience, for your knowledge, and for your nice personality. It was amazing to have you with us, and thank you very much on behalf of all my colleagues here in Tehran.
Thank you. Thank you very much.
Thank you.
Just sorry, Dr. Bandi. I see that one of our Dr. Majidi has a question. Dr. Majidi, you've sent me a private question. No.
Can you share it in the chat section so Dr.
Bandi
just
okay. So
answer in chat?
Yeah, I think it would be better. So Dr. Majidi, if you can share it in the chat, Dr. Bandi will answer in the chat section because we don't have any more time. So thanks again.
Thank you.
Thank you. Okay, let's go, Mariam, to our next honorable speaker. Let me, before that, just let me acknowledge one of our dearest friends here in Tehran, Dr. Majidi. She's one of our best colleagues here. Here she is. Dr. Majidi is one of our friends here, and she done a very great job helping us to form this wonderful session. So on behalf of our team, I should thank Dr. Majidi for short notice. She has worked as a postdoctoral research fellow in gynecology department at Yale Medical School, and currently she is working as an associate researcher in the Tissue Engineering and Pediatric Urology Research Center at Tehran University of Medical Sciences. Dr. Majidi, thank you very much, and we are honored to have you as a colleague in Tehran University of Medical Sciences. Thank you very much. So let's go to our next speaker, Professor Timur Yaronsky. It is our great honor and pleasure to have Dr. Yaronsky for our special event today. Timur is one of the leading scientists in the United States and has been working as a senior scientist and consultant at the Kerogen Corporation. He also works as an associate research scientist at the world's most prestigious universities at Yale University. During this pandemic, he was invited by several significant universities to share his ideas about COVID-19 vaccine development. We are pleased to have him here. Dear Dr. Yaronsky, it is a very great honor for us in Tehran University of Medical Sciences to have you. And this is one of the hottest topics of these days. And thank you very much for sharing your knowledge and time with us.
Thank you very much, Dr. Izan, and thank you, Miriam. Also, I would like to thank the organizers and Dr. Majidi for the invitation to present Kerogen and Yale University and to describe our efforts to develop one of the candidates for the COVID-19 vaccine, as well as to present our view on the current status of the vaccine development. So as all of you know, we are in the midst of this global pandemics, and close to 50 million people are already infected, and more than 1 million people unfortunately died due to this devastating disease. So the cause of the disease is the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. And you are probably quite familiar now with the structure of this virus, but I will remind you that this is an enveloped spherical virus about 120 nanometer in diameter. It has a large single-stranded RNA genome of about 30 kilobases. And the major feature of this virus, as well as other coronaviruses, is the spike glycoprotein. And the spike glycoprotein is very essential for the entry of the virus into the host cells. The receptor, the primary receptor for coronavirus 2 is the angiotensin conversion enzyme 2, which is primarily expressed by the endothelial cells and respiratory epithelial cells. There are also additional host factors that may facilitate entry of the virus, such as recently discovered neuropilin-1 and potentially others. But ACE2 remains to be the dominant receptor for the virus entry into the cells. The receptor binding domain of the spike glycoprotein is conformationally hidden until the spike glycoprotein is activated by the proteolytic cleavage by the protease furin. After that, the receptor binding protein binds to ACE2 with high affinity and triggers membrane fusion and viral entry. So the goal of most of the vaccines is to develop neutralizing antibodies against spike glycoprotein so that they can recognize receptor binding domain and prevent the binding of the receptor binding domain to the ACE2 receptor. And as you already know, there are many candidate vaccines that advance to phase 3 clinical trials. They use different platforms, and some of the vaccines have received conditional approval for emergency use in high-risk groups. So what are the platforms? So first of all, it's inactivated virus, usually grown in green monkey cells called Vera cells. And this virus is inactivated, so it doesn't replicate and doesn't pose any risk to the immunized patients. And several groups in China have advanced this platform and have already immunized hundreds of thousands of people. So among those is the CoronaVac by Sinovac group. There are two separate vaccine candidates developed by Sinopharm in collaboration with the Wuhan Institute and with the Beijing Institute. So these vaccine candidates appear to use a traditional platform, well proven. Of course, there are many unknowns, like whether they're going to be successful, whether there is enough manufacturing capacity. So that's why there are other platforms that attract our attention. Among those, the adenoviral vectors are perhaps the leading in terms of the number of patients that are being immunized and enrolled in the clinical phase 3 trials. So we know about the University of Oxford and AstraZeneca group that uses the chimpanzee-derived adenoviral vectors. We also know that another group in China, CanSino Biological, has developed a vaccine candidate and tested it in many subjects, and they use adenovirus 5. A Gamaleya Research Institute in Russia uses a combination of adenovirus 26 and adenovirus 5 for prime and boost, and they have also received a conditional approval. Of course, it's a conditional approval that came before completion of the phase 3 clinical trial. So we have to be a little bit cautious about this. So Janssen Pharma also uses adenovirus 26 in their vaccine candidate. So there is, besides that, there is also a novel platform that relies on delivering the mRNA that expresses spike glycoprotein. And two key players in this is Moderna, in collaboration with the National Institute of Allergy and Infectious Diseases, and BioNTech in Germany and Pfizer have developed 3 vaccine candidates and they are also continuing the phase 3 clinical trials. And one of the front runners is also Novavax, that has developed a protein subunit based on the spike glycoprotein, and they use it in combination with their Matrix M adjuvant. Besides those front runners, there are 37 additional vaccine candidates that are in early stage clinical trials. They use either the same platform, such as inactivated virus, or different platforms. For example, Inovio has a good chance with their DNA-based vaccine in combination with additional adjuvants, and several other players use this platform. Some other companies also use this novel mRNA delivery platform, such as CureVac and Arcturus, together with the Duke University and University in Singapore. Some other companies use protein subunits. There is development on using virus-like particles, which form a protein-based particles that look like a virus and contain the proteins derived from glycoprotein. And there are other viral-based vectors, and of particular interest to us is the vesicular stomatitis virus-based vectors that had been initially developed at Yale University, and several groups have advanced to the clinical trials as well, such as a group in Israel at the Israel Institute of Biological Research and Weizmann Institute, and Merck together with IAVI consortium have been developing this group. So moreover, besides these clinical candidates, there are more than 150 candidate vaccines are in the preclinical trials. So why so many, and why so many companies are trying to develop this? Well, first of all, there's no guarantee that any of the front-runner vaccine candidates would be sufficiently effective to prevent COVID-19 infection and control the pandemic. The front runners may not provide enough manufacturing and distribution capacity, so we may not have enough doses to vaccinate all the people that need to be vaccinated. And also, there are obviously some opportunities for refinement and improvement of the platforms. That's why many early stage biotech startup companies and academic centers work on improving the efficacy, delivery, storage, and cost efficiency of the vaccine candidates. And I also would like to mention that some established and respected vaccine developers apply outside the box approaches. For example, a consortium of Institute Pasteur, University of Pittsburgh, Themis, and Merck developed replicating measles virus that may provide protection against the measles and COVID-19 as a bivalent vaccine developer. So we are interested in applying our virus-like vesicle platform for vaccine delivery. So what are the virus-like vesicles? It is a hybrid artificial virus that uses an alpha virus RNA-dependent RNA polymerase, and we use specifically RNA polymerase from Simliki forest virus. We use a single glycoprotein from vesicular stomatitis virus, and this is the only structural protein in this artificial virus. We construct the DNA plasmid that encode the Simliki forest virus RNA polymerase and the glycoprotein from vesicular stomatitis virus, and we can insert any foreign antigen to induce antibody and T-cell responses once we generate virus-like vesicles. The virus-like vesicles are generated first by transfection of the plasmid into the host cells, and most commonly used host cells now for us is the baby hamster kidney cells, BHK21. And these virus-like vesicles start replicating in these cells, and they can achieve sufficiently good titers in these cells. Besides BHK21 cells, we can also use HEC293 cells, as well as the HUH7 cells. And the replication is actually quite restricted to just a handful of cell lines, and it is completely restricted by interferon responses in primary cells and in vitro. This platform had been developed by Dr. John Rose at Yale University and has the following advantages. It has flexible design and implementation that allow modification of the antigens to account for the emergent mutations of the virus. Multiple antigens may be included into the vaccine, so we can generate a bivalent or even trivalent vaccine. Double-stranded RNA intermediates of the VLV replication activate interferon responses that may provide non-specific protection before antigen-specific immune responses are induced. We can also use prime boost immunization so that we can improve the titers of the antibodies, and we can do this by switching the glycoproteins in our VLVs. We can use VSVG from Indiana vesicular virus or from New Jersey vesicular virus. These are serologically distinct strains of vesicular viruses, and this enables prime and boost immunization without the risk of inducing anti-vector antibodies. There is generally no pre-existing immunity in the population, and safety of the vaccination has been proved in mouse and non-human primate models. Let me introduce Carogen Corporation. It is an emerging biopharmaceutical company with exclusive license from Yale University for vaccine development using the VLV platform. We have issued patents for the composition of matter and method of use. We have 14 more patents pending. We have published a couple of papers recently, focusing primarily on the improving of the vaccine platform for a different indication. We call VLV as an Avidio. It's an artificial virus for infectious disease and immuno-oncology. And that is primarily because we are interested in applying this platform for multiple diseases, as well as testing the suitability of the VLV for treating cancer. The current pipeline, Carogen, has two candidates. CARG-201 is a candidate for immunotherapy of chronic hepatitis B, and it is completing preclinical evaluation in animal models. And CARG-2020 is a candidate for treatment of colorectal, ovarian, and liver cancers, and we are currently doing preclinical evaluation in animal models. So now back to COVID-19. What is the Carogen's approach to developing a vaccine? So we actually have tested multiple candidates, and so far the lead candidate seems to be expressing the spike glycoprotein. So we gene synthesized the sequence of the spike glycoprotein from SARS-CoV-2. We inserted this into the plasmid. We transfected this into the BHK21 cells. We propagated VLVs in vitro, and we started injecting this into the animals. So within the animals, this virus-like vesicle releases the RNA inside of the infected cells, and negative-stranded RNA is formed. A subgenomic RNA is transcribed from the negative-strand RNA, and spike glycoprotein is expressed from the subgenomic protein, from the subgenomic RNA, and this spike glycoprotein serves as an antigen for induction of the neutralizing antibodies by the B cells. At the same time, double-stranded RNA intermediates of the VLV replication activate innate immune pathways such as RIG-I and others. They trigger interferon response, and the interferon response helps activating the CD8 cells that may also recognize the peptides from the spike glycoprotein. And we hope that this will be sufficient to neutralize the virus. What is the current status? As I mentioned, we have tested more than 20 different VLV constructs using different permutations of the spike glycoprotein, truncated forms, full-length forms, combination of the spike glycoprotein with the nucleoprotein, using a subgenomic promoter versus T2A peptide. So all of this was done relatively quickly in vitro, and 20 candidates were evaluated in vitro for expression of antigen and replication of the VLV in substrate cells. We chose 2 lead candidates that express full length or truncated spike, and these candidates are now being tested in the mouse model. So we learned that the prime boost immunization schedule is necessary for induction of neutralizing antibodies, and the titers of the neutralizing antibodies in responding animals exceed the dilution factor of 1 to 160, and these are sufficiently good titers that should protect the animals from infection. And now we are currently planning the efficacy study in a small animal model, probably using mice with the human ACE2, transgenic animals with the human ACE2, or we could also use other models such as ferrets or hamsters. Is there a COVID-19 vaccine for pediatric population? We are certainly thinking about this, and others are doing this way as well. But there are the following considerations. Even though the morbidity and mortality due to COVID-19 are lower in children, we suspect that the vaccination of children will be necessary to curb the pandemic. The direct impact of COVID-19 on children is higher than from many other infections, so it is important to develop this vaccine for children as well. We also know that the approval of any COVID-19 vaccine for use in children will require additional phase 2 and phase 3 clinical trials, and likely those trials should stratify the subjects by the age groups. What is the current status of the pediatric vaccines? Again, Sinovac uses an activated virus, and they have started the phase 1 and 2 combined clinical trial using children as the subjects in age from 3 to 17. 2 players have been developing adenoviral vectors, also started the clinical trials and started enrolling the children aged from 5 to 12 or 6 to 17. Pfizer and BioNTech that have been developing mRNA-based vaccines enroll children older than 12. And there is another group in China that uses a completely different platform, artificial presenting cells. They have just started phase 1 clinical trial, and they enroll children older than 6 months. So what is the take-home message from this presentation? So our view is that if all goes well, several phase 3 clinical trials of the vaccines will reach conclusions by the end of 2020 or beginning of 2021. The competition for safer and more efficient vaccine will continue within and between multiple platforms, and will likely lead to an effective and widely available vaccine for adults in 2021. COVID-19 vaccines available for children will require additional evaluation and approval and may come later, albeit and hopefully with additional benefits. And vaccine candidates that take longer to develop and test, such as an example is a vaccine that being developed by Carogen, we may catch up, and we will certainly keep in mind the pediatric applications for our vaccine candidates, as well as other developers will pay attention to the pediatric population. And I'm certain that we cannot defeat COVID-19 pandemic without vaccinating children. So in conclusion, I would like to thank Dr. John Rose, who developed the platform, the virus-like vesicle platform, and the Carogen's COVID-19 response team, Bhaskar Medina, a principal scientist in the group, Mary Crady, senior scientist, Valerian Nakar, co-founder, vice president for research and development, and Dr. Bijan Almessian, a co-founder, president, and CEO of this company. And thank you very much for your attention, and I'm happy to answer any of your questions.
Okay, so Dr. Yorvinski, thank you so much for your great lecture and your for joining us and also sharing your time and expertise with us. It was really an honor to listen to your lecture. So thank you for that. So I see a question in the chat section right now. Actually, it was a private question. It was sent privately to me, so I will read it for you. Are pregnant women being included in the phase 3 trials? They were excluded from previous trials of vaccine for emerging viral infections, such as Ebola.
My understanding is that pregnancy is an exclusion factor for most of the clinical trials. They were excluded from phase 1 and phase 2 for sure. Within the phase 3 trials, an established pregnancy serves as an exclusion criteria for most of the trials. But as we all know, it cannot be completely ruled out. And in the course of the proceedings with the vaccine, because the vaccination requires prime and boost, that means that it is very likely that some of the subjects in phase 3 clinical trials will present pregnancy during the course of the trials.
Okay, so thank you for your explanation. So another question is being.
Sorry, just a question, a quick question, Timur. There was a vaccine that was claimed by Russians a few months ago that they have built or make a vaccine. Have you any information about that?
Well, so what you probably refer is to the vaccine from the Gamaleya Research Institute, the adenovirus-based vaccine. Is it right? Okay.
Yes, sir.
So, I mean, what I know is like they're certainly manufacturing it, and they're expanding the vaccination based on this conditional approval. The phase 3 trial has not been completed, so I'm not quite certain about the manufacturing scale. It is based on the adenovirus production, so it has certain limitations and bottlenecks, and the quality control is quite important. I don't have any insider information, even though I am originally from Russia and I try to keep it up. It's not a fully transparent process, as you may probably know, but the Ministry of Health in Russia is very keen on scaling up and even offers this vaccine to other countries. Of course, we have to be a little bit cautious about how this will actually work. I'm personally quite concerned with the fact that they use adenovirus 5 as the booster vaccination, because there is quite a large number of people who have pre-existing immunity to adenovirus 5, and the vaccine with adenovirus 5 alone showed less than desired safety profile, and it has questionable efficacy profile.
And just $1 million question: is it possible? Is it for us, for the countries just like Iran, or I can say the countries that are not in direct relation with the United States, and they are somehow in lack of money? When you expect we can have the vaccine for our people? What is your time prediction for that to happen?
Well, my understanding is the following. There is a consortium for emergency preparedness, and it's called like CEPI, C-E-P-I. And it is based in Norway, and it is an important player in the vaccine development. And actually, it was founded way before COVID-19 became to place. They learned the lessons from the SARS, and they have supported studies in vaccine development for MERS, like another coronavirus vaccine, and so on. So I would say, like, the countries with fewer resources to put into the vaccine development and scale up may pay attention to what CEPI is working on, and they provide substantial funding for the companies on terms that allow these vaccines to be distributed not only to the countries of the origin of the developers, but to other countries, regardless of the gross domestic product or per capita or like the wealth of the country. So the idea of the CEPI is to make the vaccines available to other countries. And what's important is not just like the vaccine itself, but how it is going to be stored. For example, most of the current vaccine candidates require storage at -80 degrees. And, like it's not feasible to distribute those vaccines under these cryogenic conditions. So that's why CEPI and other organizations work hard on this. The Bill and Melinda Gates Foundation is also trying to support efforts in this direction.
Thank you very much. It was very informative, and I should thank you again for your time and for your knowledge. If there is any other
actually, yes, there's another question in the chat section. So they're asking, Dr. Majidi is asking that, is there any difference in the efficacy and nature of COVID-19 vaccine considered for children rather than those of adults? Do they differ or they have same efficacy?
At this point, there is not enough information to tell anything about efficacy. So like the vaccines that are intended for use in children, they are like in phase 1 and phase 2 trials. What they actually do is they do test the dosing, because the consideration is that the dosing for children may have to be reduced, not just like by the body weight, but perhaps also with other safety considerations. So unfortunately, I cannot really tell. The anticipation is that the immune response in children should be much more robust and vigorous than in older population, like those above 60. So it might be possible to actually achieve better efficacy to prevent infection completely, but this is just a prediction.
So we just have to wait. Thank you so much, Dr. Yurinsky. Thank you so much for joining us again and sharing your time. And it was really an honor to listen to this amazing lecture. So thank you so much again.
Thank you. It is my pleasure to join this Congress.
So we're going next to Dr. David Schwartz, our next speaker. Dr. Schwartz, if you can hear me, I can see that you've opened your video. Okay, so I'm going to give our audiences a small introduction about Dr. Schwartz, whom graciously have accepted our invitation to join this Congress. So Dr. David Schwartz is a clinical professor at the Medical College of Georgia in the USA and has an educational background in tropical medicine, emerging infections, maternal health, anthropology, and medical epidemiology and public health. He has professional and research interests in reproductive health, diseases of pregnancy, and maternal and infant morbidity and mortality in both resource-rich and resource-poor countries. In the field of medicine, his subspecialties include obstetrics, placental and perinatal pathology, as well as emerging infection. An experienced author, editor, investigator, and consultant, Dr. Schwartz has long experience investigating the biomedical, anthropological, and epidemiologic aspects of pregnancy and its complications as they affect society, in particular among indigenous populations and when they evolve emerging infections. And Dr. Schwartz is also the chief editor of the Springer Nature book series, Global Maternal and Child Health, Medical, Anthropological, and Public Health Perspective, and he's currently involved with maternal-fetal neonatal aspects of the COVID-19 pandemic. He has worked on this topic with Ebola virus, Zika virus, Lassa virus, HIV, and other infectious diseases globally. So thank you, Dr. Schwartz, for joining us again, and we are more than eager to listen to your lecture about the vertical transmission of this damned virus. So I've sent you a request to unmute
Okay.
yourself. Yes, we can hear you.
Am I unmuted?
Yes.
Great. And let's see, share screen, host disabled, participant
No,
screen
no.
share.
Let me check again.
Yes, I'm
Just,
disabled.
Yeah, I'm going to make you a co-host now. Yes.
Okay.
Okay, so you might see it now. Do you see it
Okay.
now?
Let's see. Yes.
Okay, perfect.
Is that good?
Yes, we're good to go.
Okay, let me just go back here.
Just
my
choose the
team-
slideshow.
I'm getting all sorts of warning messages here.
Oh my God. I hope they're not serious.
Let's see. Show. Let's see. I'm sorry, I'm having all sorts of technical issues here.
No, that's totally fine. Is there anything I can do to help?
Well, I see a tiny little thumbnail here. Hide thumbnail. I'm trying to get back to my full screen and it's kind of disappeared.
Actually, we are seeing your screen right now.
I've lost my presentation. Your screen sharing is paused.
We haven't paused you. Let's start again. So I've stopped your screen sharing.
Okay.
And let's start it from the beginning.
Okay.
So you have your PowerPoint presentation minimized, yes?
Yes.
Okay,
Share
so
screen.
click on the share screen, yes, and choose the windows. Yes.
Okay. Can you see it?
Yes.
Great. Wonderful. Can you see me?
Yes.
Okay. Well,
just
great.
choose as it slideshow, sir. This is a sign there on the top of your screen. It's just like a cup, I think. Yeah. Just no, you have passed the sign.
Good.
So you can see there's file, home, insert, design.
Yeah, that's it.
Yes.
Okay.
Yes.
Okay,
Perfect.
great. Well, thank you. You can see I'm technically challenged.
No worries. No worries
No
at all.
worries.
But thanks for your patience and thank you for inviting me. I'm very honored to be speaking to y'all from Atlanta, Georgia. I'd like to thank the previous speakers. Those were very interesting talks. And I learned a lot. So I want to thank you for that. What I'd like to talk to you about is the mother-infant transmission of COVID-19. And, I'm unfortunately, again, I'm having a technical issue. I can't see my screen because this block is so large.
Which
Can
block?
I hit the hide thumbnail video?
Yes.
Great, perfect. So I've been involved with maternal-fetal aspects of this terrible, terrible infection really since the beginning of January with the Chinese in consultation. And previous speakers have discussed this as it began in China, but typical with epidemics and pandemics of newly emergent infectious diseases, especially viruses, knowledge of the disease in pregnant women and fetuses and children lagged behind our knowledge of the infection in non-pregnant adults. And having been doing this for over 40 years, I've unfortunately been around for many pandemics, and this is very typical of what we see. We don't usually know much about the emerging infection in pregnant women for some time. And then, just because of the physiology of pregnancy, we don't really have knowledge of the disease in neonates and children for some time even later, just because of the gestational period in humans. And so back the end of January, my colleague Ashley Graham and I put together an outline of what we might expect from this infection were it to occur in pregnant women. And what we did was we looked at previous pathogenic coronavirus outbreaks. And of course, SARS, severe acute respiratory syndrome, and MERS, Middle East respiratory syndrome, were the two major coronavirus bad actors in terms of causing epidemics. And as we look back at these as models for perinatal infection, what we found was that, yes, they did cause maternal morbidity, and yes, they did cause maternal mortality or death. And they did cause perinatal morbidity and mortality. But from an epidemiological standpoint, there was never a confirmed case of vertical infection in either SARS or MERS. And so we literally had no information about the transmission of coronaviruses to infants from their mothers. So what we decided to do again fairly early in the pandemic was Amareen Dhaliwal from Boston University and myself also decided that we would epidemiologically model the condition of these viruses and related viruses in pregnancy through the medical literature and frankly through history. And so at the time, SARS-CoV-2 was considered a respiratory RNA virus, as was MERS and SARS. But we also decided to look at other major respiratory RNA viruses. And of course, these included things like metapneumovirus, HPIV, respiratory syncytial virus, and influenza. Of course, you know, these non-coronavirus diseases are frequently prevalent in infants and children. And so when we look back at the history of these respiratory RNA viruses, trying to get a handle again on how respiratory RNA viruses behave with pregnant women, fetuses, and neonates, what we found was there was almost no evidence that these infections could spread from an infected pregnant woman to the fetus. There were a few exceptions, primarily in the area of influenza virus, but they were a handful. And you have to realize, of course, that influenza, affects millions of people a year, and the literature went back many decades. And so to have these tens of millions of global influenza cases and yet have a handful of case reports of maternal-fetal infection indicated to us that, in fact, it was not a significant risk factor, and that modeling what we would expect with SARS-CoV-2 in pregnancy indicated that if it did, in fact, end up crossing the placenta, which there was no evidence of at that time, that it would do so very, very infrequently. Also, about the same time, a little earlier, I decided to look at what we were seeing coming out of Wuhan, China, and other areas in China in terms of the initial data on pregnancy-related infections with SARS-CoV-2. And so I looked at 38 pregnant women who had COVID around the time of delivery and wanted to see what was the effect, not just on maternal health, maternal morbidity, and maternal mortality, but also to examine neonatal outcomes, in particular from an infectious disease transmission standpoint. At the time this came out, and again, now this is all considered old literature, but I think at the time this came out, this was the largest cohort of published pregnant women with COVID in the literature. And what I found was that, in fact, based on these cases from Wuhan and its immediate environs, that COVID-19 was not especially pathogenic in pregnant women. There was the occasional case where severe or critical pneumonia developed and mechanical ventilation was required. But other than that, the disease seemed to either be asymptomatic or very mild in pregnant women. And it was the same when you looked at their infants. And in fact, I looked again in particular at the transmission status, and none of these women had transmitted the virus to their infants. Right around the same time, there were other cases coming out of China being published, smaller cohorts. And again, there was really no firm evidence of neonatal infection occurring to any great degree. There were a few suspicious cases of newborns who were published, and interestingly enough, they were initially published in the mass communications literature, not in the medical literature. And so we read about these via magazines and newspaper and online reports. But for all intents and purposes, we weren't really seeing neonatal infection. And in those few cases where it was reported, the origin of that infection wasn't certain. These babies had not been tested until 2 or 3 days following delivery for the most part. And so we weren't even sure that they weren't acquiring the infection from the hospital environment or another source like that. But once this disease started to spread, and of course it went to the Western Hemisphere, it went to the Middle East and to Europe, we began to have additional reports of neonates testing positive for COVID-19. And as we looked at these cases, as they were being reported in the literature, and again, this is now many months after the pandemic was initially recognized, we weren't really sure how these babies were acquiring their infection. And although in many of them, especially those that tested positive very early in life and had been isolated from their mothers and other precautions, we just weren't even sure if vertical transmission was responsible for that infection, but we certainly suspected it. So when we talk about vertical transmission of viral diseases, what exactly are we talking about? I'm an editor of several journals, and unfortunately, I see the term vertical transmission being incorrectly used in some cases. Some authors equate vertical transmission with maternal-fetal transmission. That is not what it is. In epidemiology, vertical transmission is simply transmission from mother to infant. It can occur before or after birth. And there are 3 major potential mechanisms of vertical transmission. The first is intrauterine, and that's divided into 2 types, transplacental and ascending. An ascending infection arises in the maternal cervicovaginal canal, and then it ascends up the maternal cervicovaginal canal to reach the uterus, where it can potentially infect the placenta and the fetus. The hallmark of this pathologically is the microscopic finding of chorioamnionitis. And we typically see this in bacterial infections. This is what you would see typically with E. coli, with group B strep, with Klebsiella, etc. We don't see it very much with viral diseases. The other form of intrauterine vertical transmission would be transplacental. And this is where the infectious agent literally crosses the placenta, going from the maternal circulation to the fetal circulation. We also term this hematogenous infection. And this is the typical form of transmission that we see with viral diseases, such as Ebola, Lassa fever. We can see it with some others, Zika. The second form of vertical transmission is intrapartum. This occurs when the baby is being delivered through an infected birth canal. And so the baby acquires the infection transiting the vaginal canal during delivery. And in terms of viruses, the two major viruses that are transmitted like this would be herpes simplex virus and human papillomavirus. The third form of vertical transmission would be postpartum infection following delivery. So the baby is born, it is uninfected, but then it acquires the infection after delivery. And this could be through maternal contact, maternal respiratory contamination, physical contact with the infant, or through breast milk. I'd like to talk a little bit about the torch complex of infections. I know all pediatricians are familiar with torch infections. Torch infections was a term first coined by my colleague here in Atlanta, Dr. Andre Namias, back in 1971. Andy is a very dear friend of mine. He is still living. I run into him in the food stores sometimes, but he's been retired for many years. And when Dr. Namias first coined this term, it referred to infectious agents that could infect the fetus prior to delivery. It was really a major find to classify these agents like this. They're typically characterized by intrauterine and intrapartum transmission to the fetus. They're not all viruses. Some are bacteria and some are parasitic. Most, but not all, have the capability to have transplacental transmission. Now, the previous coronavirus infections we saw, SARS and MERS, technically aren't torch agents because we never were able to demonstrate conclusively that the infection could spread from mom to a baby. So if we just look at transplacental transmission of infections, so that would be the group of vertical infections that are transmitted in the intrauterine environment from the maternal bloodstream to the fetal bloodstream through the placenta. This form of transmission occurs with many viral agents. Things like cytomegalovirus, rubella, Ebola, Zika, HIV, hepatitis B, and then rarely some other viruses. Parasitic infections can be transplacentally transmitted. These include Trypanosoma cruzi, which is the etiologic agent of Chagas disease in Latin America, and toxoplasmosis. And some bacterial agents can as well. The typical example would be Listeria monocytogenes. So very early in the pandemic, we asked ourselves, number one, was fetal infection occurring? And then number two, was SARS-CoV-2 transplacental? Could this virus, unlike the two previous pathogenic coronaviruses that we experienced, could this coronavirus cross the placenta from an infected mother and infect the fetus prior to delivery? And so how would that happen? Well, the virus would have to cross what we call the maternal-fetal interface. The maternal-fetal interface is a very complicated system that involves multiple cell types and very complex biochemical mechanisms. But essentially, it is one of its major functions is to protect the fetus from infectious agents, at the same time as allowing the good stuff that the fetus needs from the mother to be able to pass into the placenta. And so when we look at maternal blood entering the uterus through the maternal spiral arteries, which are branches of the uterine artery, they then, as you can see on the figure on the right, they then squirt maternal blood into the base of the placenta. And you see that those little arrows down there. That maternal blood should not cross into the fetal circulation under normal circumstances. But what it does is it bathes the chorionic villi. And the chorionic villi are the fetal structures of the placenta. They make up the bulk of the placental parenchyma, or solid tissue. And within them is a branching network of fetal capillaries that we call the villus capillaries from the chorionic villus tree. And so these villi are lined by a protective layer of cells called the trophoblast, the outer layer of which we call the syncytia trophoblast, which, as you will see in a few minutes, will become very important here. And so the syncytia trophoblast is the major protective cell layer. It's the major cellular barrier that defines the maternal-fetal interface. And so in general, if something like an infectious agent is going to cross from the maternal circulation that's circulating through the intervillous space of the placenta and cross into the fetal bloodstream of the placenta, it's going to have to pass through this cell layer called the syncytia trophoblast. In August, a very important article was published by my colleagues from Italy, Luisa Patain and colleagues. And this was published in the American Journal of OB/GYN MFM. And what they did was they identified in two placentas, of transmitting cases that the fetal cells of the placenta were themselves infected with SARS-CoV-2. In other words, they had two mothers out of a cohort who not only tested positive for COVID-19, but the neonates tested positive for COVID-19, and the placentas had been collected and saved and examined pathologically using molecular methods. And they were able to identify, both via antibody analysis and RNA analysis, that the virus had infected the fetal cells, specifically the syncytia trophoblast, of the placenta of these two infected maternal neonatal dyads. That was a major, major find. And what that meant was that, in fact, this likely represented intrauterine maternal-fetal transplacental infection. Remember, the placenta is the baby's organ. It's the baby's largest organ. It's just not in the baby. And so when we see infection in things like syncytia trophoblastic cells, that is fetal tissue. And this is an image. This was not published, but this is an image from one of those placentas, courtesy of Denise Murati, who's the second author on that article. And what we were seeing in these placentas, beside viral positivity, was a previously quite rare microscopic abnormality called chronic histiocytic intervillositis. And this means that within the intervillous space between the chorionic villi, there was a dense inflammatory infiltrate composed of macrophages or histiocytes. This had been described before, but never related to an infectious agent, and in fact, as a very, very unusual finding. And as you can see in this high power field, all of these little blue dots that you're seeing, well, most of them, are histiocytes or macrophages, and they are filling the intervillous space here. And I don't know if you can really tell, but the trophoblast here is showing quite degenerative changes. We're working so we're all working so rapidly on this that as I was waiting this morning to speak, I had an email from my colleague, Professor Kristen Thomas at Bellevue Hospital and New York University in New York, who was working on a case with me. And she sent me these pictures. So these pictures are literally about 2 hours old. And this is a placenta from a stillborn infant of a woman with COVID-19. The babies had a nasopharyngeal swab at the time of autopsy that tested positive for COVID. And this is the placenta that she literally just photographed with an antibody stain to macrophages called CD68. And all of these brown staining small objects are a dense infiltrate of macrophages or histiocytes within the intervillous space that are completely surrounding these chorionic villi. And again, this is extremely unusual. And this placenta, again, was positive for COVID-19. This is back in Italy again on the case we were previously talking about. And this is what we call an RNA in situ hybridization. This is a molecular pathology test that's a little different than RT-PCR that we do in clinical testing, because here we're actually doing it on the tissue. As a in situ hybridization technique, we're matching up RNA, complementary RNA sequences here. And so we can detect SARS-CoV-2 virus in tissue and localize it. We can actually see where it is. And as you see here, these are chorionic villi that are outlined by this brownish granular material. That brownish granular material surrounding these villi is all SARS-CoV-2. It has a very large viral load. Frankly, more so than I've probably seen with any infection. And I work with Ebola virus. So this is just a very large quantity of virus that has infected the syncytia trophoblast, the major cell layer of the fetal maternal barrier in the placenta. And again, this is from a transmitting maternal fetal dyad. On that case, we also did other tests, including antibody. And this is another molecular pathology test. This is an actual antibody to the SARS-CoV-2 virus in that same placenta. And again, you can see the same pattern of syncytia trophoblastic dense staining in these chorionic villi. This is just remarkable. And in fact, some cells in the intervillous space even look positive. Those are maternal cells. This is another picture I literally just got. And what we're seeing here, again, in the dense brown, is a RNA scope. It's an RNA in situ hybridization of a chorionic villus in the placenta, staining positive in the trophoblast. That's what all that brown staining is. And then you can see those areas of red globular staining. Those are placental macrophages. Those are fetal macrophages in the chorionic villi called Hofbauer cells. And look how close the virus is in the syncytia trophoblast to those chorionic villus macrophages of the fetus, those red cells. That's just an incredible image. I want to show you, as a comparison, just how much virus there is in these placentas. I was on the team that we believe was the first to localize the Zika virus in the placenta back in 2016. And on the right, you'll see an image with a little red arrow. This was published in the Archives of Gynecology and Obstetrics. And that's a chorionic villus from a baby with congenital Zika virus infection. And that little red arrow is pointing to a placental macrophage, a Hofbauer cell, that is positive by RNA in situ hybridization for the virus. That's all the virus there was in that chorionic villus, is that little dark dot at the arrow. And just look at the difference between the viral load in the placenta with Zika virus infection and with SARS-CoV-2. It's very dramatic. And so it appears from our work that COVID-19 is the newest torch infection. So fairly recently, I guess about a month ago, myself and my colleagues, including my colleagues in Tehran there, Babak Beji, Farshad Moshfegh, and Nazanin Zafranlo, as well as Louisa Patain from Italy, we published an article in which we proposed both neonatal and molecular pathology criteria for the confirmation of intrauterine infection of the placenta in fetus. In other words, what we proposed and shared in this article were criteria to be able to recognize those infected neonates who had acquired their infection in utero via transplacental transmission. And what we were doing in this article was to look at a variety of different techniques from a critical standpoint, and then look at molecular pathology techniques that I just showed you, things like RNA in situ hybridization and immunohistochemistry using specific antibodies. And in those cases where we had placentas for examination, we would be able to then determine whether or not an infected neonate had acquired his or her infection via transplacental transmission. Now, very recently, another important article has come out in Nature Communications from Roberto Richetti and his colleagues in France. And what they have done is they have looked at the time, the published cases of neonatal SARS-CoV-2 infection that they could find in the literature. And this article, I believe, has only been out for about 2 weeks. And they found in the world's literature 176 published cases of neonatal SARS. And they attempted in this article not only to review these, but to try to determine statistically and clinically whether these neonates were acquiring their infection via postpartum transmission or intrapartum transmission or via intrauterine transmission, which they called congenital transmission. And their results were very interesting. Looking at this meta-analysis of 176 published cases of neonatal COVID, they believe that 70% of these cases acquired the infection postpartum. So approximately 2/3. Approximately 1/3 of neonatal COVID-19 infections, they believe, were acquired by vertical transmission. In other words, mother to infant. And 9% of confirmed vertical transmission versus probable or possible. 3.3% were intrapartum and 5.7% intrauterine or congenital. So about 6% of all neonatal cases of COVID-19, in their opinion, were acquired in the intrauterine environment. About, you could round that off and say 1 out of 20. Of the cases, of the published cases they reviewed, the largest cohort of neonates was published from Iran. And doctors Mohagegi, Beji, Zafranlo, Moshfegh, and Yazdani and myself put together these 19 cases of neonatal infection in Iran and looked at a variety of factors and obviously characterized them to the best of our ability given the clinical information that we had. And perhaps one of the most interesting findings, which goes into the title, is that there was quite a bit of variation in the timing of test results, clinical findings, and outcomes. Some babies initially tested positive and then tested negative. Some initially tested negative and then tested positive. We had multiple gestation infants that had disparate testing results and disparate outcomes. It was really quite a mixture of factors in these newborns. Unfortunately, we did not have any placentas to look at from this cohort of 19 neonates. So a couple weeks ago, my colleague Kristen Thomas at New York University, who I showed you the picture she just sent me this morning, Kristen and I published an article in the Lancet eBiomed. And what we tried to convey in this article was that using a protocol of comprehensive molecular pathology testing, that is, testing using in situ RNA hybridization, RNA scope, and immunohistochemistry with antibodies to the virus, we would be able to characterize the occurrence of maternal-fetal transmission prior to delivery. And we encouraged the use of these techniques where they were available for this type of determination. So, to come to the end of my presentation, for everything we find, there's 20 new questions that occur. And I guess that's rather typical of something like a new infection. So we ask ourselves, does placental infection always mean that the fetus will be infected? Well, I can tell you that, from some data that we have, we're actually working on 3 articles right now, but from some data we have, we do see cases of placentas that are infected using these molecular methodologies where there is apparently no fetal or neonatal infection. Another question, are there placental risk factors for transmission to the fetus? And a group of my colleagues globally and I are, as I sit here working on an article to address that, yes, there are placental risk factors apparently for transmission from mother to the infant among which is the occurrence of this lesion called chronic histiocytic intervillositis. Why are so few placentas and neonates infected from pregnant women with COVID-19? How and when does the virus cross the maternal-fetal interface? And of course, an important question, and this is something that has come up, as you know, with Zika virus infection, is neonatal infection associated with long-term effects? So hopefully we will all try to answer these questions and many more in the months to come. Thank you very much for your patience and listening to this. I'm happy to answer any questions.
Thank you, Dr. Schwartz, for this amazing lecture and these informative and also educational and up to date, and it was really actually up to minutes. So thank you so much for
up to the minute.
Up to the minute, exactly. So thank you so much for sharing and also joining us and giving us your time. So I see a few questions in the chat section. If you can answer them briefly, because we have 2 other lecturers after you. So
Certainly.
the question, yes. So the first question that I'm seeing is about the method of birth in PCR positive mothers. So do we prefer section, cesarean section, or an NVD?
So if I understand that, we're looking at essentially safety of cesarean section.
Yes. Yeah.
Well, you know, I'm not an obstetrician, but I've been involved in this issue for some time. And of course, we know that when this infection started in China, it was my understanding from my colleagues in China that essentially all infected women were undergoing cesarean section, or almost all. And then this trend continued in other countries as the infection spread. And we've actually seen now a decrease in the performance of cesarean sections in COVID-19 positive women. You know, I think that's an obstetrical management issue. Certainly, there are factors that need to be involved, including the safety of the mother as well as the safety of the fetus and infant. Some moms can be very, very sick. We've had a number, as you know, of cases of pregnant women with not just severe pneumonia, but critical pneumonia, requiring mechanical ventilation, who are pregnant. And so, you know, how you deliver these women in some cases isn't just dependent on the safety of the baby, but it's also on the safety of mom.
Okay, so thank you so much. So I'm seeing another question about the okay, so
sorry, sir. We are in the shortage of time, and I think we shall go for our next lecturer. And if you can please answer some questions in the chat section for us. It would be very great if you just answer them there. And I'm so happy that I have heard some of the names of my colleagues in Tehran University of Medical Sciences, such as Dr. Beigi, who is a good friend of mine, who is neonatologist and a very good friend of mine. Thank you very much for your time and sharing your valuable knowledge with us. So if you can just answer the questions in the chat section, that would be great for us.
Okay, thank you, Dr. Ahsan.
Thank you very much. Thank you, sir.
Thank you, Dr. Schwartz, for joining us again. It was really great to meet you.
Oh, thank you.
Okay, so without wasting any more time, I'm going to start. I'm going to ask Dr. Jose Antonio Castro-Rodriguez to start his lecture. So I'm going to introduce him for you guys a little bit. So Dr. Rodriguez is a pediatric pulmonologist and also an associate professor at Pontificia Universidad Catolica de Chile. I hope I pronounced it right. And he's also the winner of a research prize from International Union Against TB and Lung Diseases from Canada, and also a Master of Pediatric Pulmonology in Latin America Society. And he's going to talk about asthma and COVID-19. So Dr. Rodriguez, we are really sorry if you had to wait a little bit. And also we thank you for joining us and sharing your time with us.
I should thank again Dr. Jose. Thank you very much, sir. I know you are a very busy man, and you miss your lunch because of us. And I promise you, whenever you have time and you can come to Iran, you will be my guest of honor to go out and have a lunch, have an Iranian lunch with us.
Okay, thank you.
Yes.
Thank you, sir.
Thank you, Jason. I don't know if you see my 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 share, my
No, not
screen.
yet. I just made you a co-host right now, so you can share your slides now.
Okay. Now you can see my
Yes,
screen.
yes, we can see them. Yes.
Okay. Thank you very much. And for me, it's a wonderful pleasure to speak with you in Iran, such a beautiful country with a very high, very rich archaeology and food. So in these 25 minutes, I'm going to tell you what is the relation between asthma and COVID-19 in children. And this first meta-analysis came from adults. In this first meta-analysis, they compare 5 primary studies, more than 700 adults with asthma compared to 8,000 non-asthmatic. And they found that having asthma is not a risk factor for mortality due to a COVID compared to those without asthma. In the second meta-analysis, a high number of primary studies were involved, 14, 14 primary studies, more than 17,000 of adults, and they found the same, that asthma is not a risk factor for mortality due to COVID-19, and also asthma is not a risk factor for have more severe disease. So in May, we done this first meta-analysis in pediatric population, and in this systematic analysis, we found 126 primary studies, but only 2 have data on asthma. One study came from United States from the CDC report saying that almost 12% of children who had COVID has also a chronic lung disease, including asthma. They do not separate these diseases. And the other study came from a hospital, a tertiary hospital in New York, and found that among all of the 46 children that need hospitalization due to COVID, only 23, 24 had asthma. After systematic review, we done 2 more primary studies appear. This is the other study, came from the Chop University in Philadelphia, and they found that among 400 kids with COVID, in 21% they had an asthma as a morbidity or a comorbidity disease. And from Duke University, and they compare children without SARS-CoV-2 infection and those with SARS-CoV-2 infection. And you see that asthma has a lower prevalence in those who SARS-CoV-2 infection than in those without infection. So asthma is less prevalent among children with COVID-19 than those that do not have COVID-19. And we just finished this big study that was published 4 days ago in this Metrics preprint. And we done a multinational cohort, involved 25 different pediatric departments in 15 countries globally. And among sorry, among 1,000 of children, asthmatic children between 4 to 18 years compared to 500 non-asthmatic controls, we found that during the pandemic in these different 15 countries, children with asthma has significantly less upper respiratory infection, significantly less pyrexia, less consulting to the emergency department, less hospitalization, need for treatment, acute asthma exacerbation, or hospitalization due to asthma than in the previous year. The story is not complete if we do not divide among the different asthma phenotypes. For example, this big national cohort study from South Korea, more than 200,000 adults, they found that asthma is a risk factor for COVID only among those who have non-allergic asthma. But if you have allergic asthma, you do not have more risk to have COVID. If you are non-allergic asthmatic, you have 34 more time, for 34% more time to have asthma. And also the severity of COVID depends on the type of asthma you have. If you have non-allergic asthma, you have 4 times more risk to have a severe COVID disease than if you have allergic asthma, you don't have more chance to have a severe disease. So if you have allergic asthma, doesn't matter for being more sick, and also doesn't matter for have longer hospitalization. But if you have non-allergic asthma, you have 4 times more risk to have COVID disease, and you spend 4 days more in the hospital than the controls. And this experimental study done in the United States in children, when they found that in nasal epithelium of children who have asthma and also were sensitized, they have significantly less AC2 expression. You know that AC2 expression, AC2 expression is the receptor for SARS-CoV-2. And also if you have allergic asthma and you been sensitized, you have less AC2 expression in the nasal epithelium. Also, in the bronchial epithelium and in the nasal epithelium in children where after an allergic challenge test, those who have allergic asthma have significantly less AC2 expression in the nasal and in the lower airway tract. This other study showed basically the same. If you have allergy, you have less AC2 expression in the nasal epithelium cells. And also, if you do not have an asthma control, you are asthmatic, atopic asthmatic, you have less AC2. If you have more Th2 inflammation in the airway, you have significantly less AC2 expression. This study told also the same, and we know that most of the acute exacerbation in asthma occur due to respiratory infection. In this study from Philadelphia show that when the pandemic started in the United States in March 18, when the COVID started in the United States, they have a 76 drop in asthma visit from severe disease in red, only urgent visit, and non-urgent visit due to asthma. The same happened in UK. They compare three different years, 217, 218, and 219. In these different 3 years, the admission to the emergency department due to an asthma status or asthma exacerbation decreased significantly during the school Easter vacation. But in this 2010, the decrease of asthma visit to the emergency department decreased when London was declared a lockdown. And in blue, you have the air contamination, the PM10, and doesn't change very much in these years. The same happened in the United States. They compare air pollution during the pandemic between March 18 to May 17 compared to the previous data, and they didn't see a significantly decrease on air pollution in that city. But also they found that rhinovirus infection significantly decreased during the pandemic in United States. It doesn't happen for influenza A and B or for RSV. And the conclusion of that study was that after the pandemic, of course, they see more asthmatic patients due to telemedicine. They have less acute exacerbation, less need of systemic corticosteroids due to an acute asthma, and maybe because they have less rhinovirus. The air pollution, they measure these 4 different contaminants were similar to the previous year. So maybe more than a decrease of air pollution during the pandemic, we see this less asthma consultation or asthma exacerbation due to a less rhinovirus season. And what is the reason of that? This study, this experimental study from United States, show that in human nasal tissue culture, if that culture were infected with rhinovirus, you have significantly higher AC2 expression in the nasal tissue culture than controls. So these other studies demonstrate the same. That the rhinovirus upregulate the expression of the AC2 and this other receptor called SARS-CoV-2. And if you have a patient with asthma, with symptomatic asthma, for example, with higher exercise-induced bronchoconstriction, you have significantly more AC2 expression. So you are more prone to develop, to have an SARS-CoV-2 infection than if you have an asthmatic with low exercise-induced bronchoconstriction. That means with asthma control. And another important finding in this last month is that inhaled corticosteroids can decrease the AC2 expression in the sputum. You see here that if the patient, asthmatic patient, are on or with high ICS, high inhaled corticosteroids, they have significantly less AC2 expression in the sputum than those asthmatic without therapy, without treatment. And what happened in the different corticosteroids, they found that among all the inhaled corticosteroids, this cyclosenide blocks significantly more copy of SARS-CoV-2 than the other corticosteroids. So, as we know, asthma is an heterogenic disease. Maybe children and adolescents are less risk to asthmatic children and adolescents have less risk to develop or to have COVID-19 than older subjects. That is more prone in high type 2 asthma than in those who have non-allergic asthma. So if you have an asthmatic with more Th2 cytokines, you have less chance to have COVID-19. If the asthmatic have lower IL-6, lower allergy sensitization, and have a less degree of severity of the disease, if they have more normal lung function, well-controlled asthma, non-exacerbation in the last year, and use more inhaled corticosteroids, those are protective factors for having COVID. On the other hand, if the patient have less Th2 asthma, or they have diabetes, hypertension, obesity, or more severe asthma with several or frequent exacerbation, with impair of lung function, or use oral corticosteroid frequently during the year, they have more risk to get COVID-19. In terms of treatment, we know that nebulization is not allowed for treat asthmatic, especially during the asthma attacks. So what happened with those children with very severe asthma attack? And we did this randomized clinical trial that was the first randomized clinical trial done in very severe asthmatic. We recruit more than 100 children with a severe asthma exacerbation. Severe means that the mean of saturation, oxygen saturation, was about 86, 85. So were very severe children. And we compare two groups. We randomized to receive MDI with salbutamol mass ipratropium by MDI or by nebulization. Both groups receive methylprednisolone and magnesium sulfate, EB. And after 4 hours of treatment, children who receive albuterol or salbutamol plus ipratropium by MDI and using oxygen by cannula, increase significantly more the saturation and also are more prone to leave the emergency department and do not need hospitalization than those children who receive the same drug but by nebulization. And we we are hope to start the next week this other study when where we are trying to use this SOBIC. This SOBIC is a new rapid simultaneous oxygen and PMD bronchodilator device. So Dr. Peter Goldman and Newhouse, those who invent 40 years ago the aero chamber, developed this system where you can administrate the drug using MDI plus oxygen in the same device. So for those who need oxygen during the attack of asthma, you can administrate the oxygen in the drug in this simple device, and they add this COVID-19 filter. So maybe the next year or the next 2 years, I can tell you what will be the result. What was the result of this new study? So my conclusion are that asthma in children seems not to be a risk factor for death or have more severe COVID-19. However, we need more data, and control asthma might be a risk factor to have a more to have a greater AC2 receptors. The absence of other respiratory viruses play a role for the morbidity among asthmatics during this pandemic. We know that RSV increased the AC2 receptor in the lower tract. Atopic asthma have less AC2 receptor versus non-atopic asthmatic. The use of high ICS doses decrease the AC2 receptor in the airway. And for those cases with a severe acute asthma, we recommend to use MDI with oxygen by cannula than use nebulizer. Many thanks for your patience and hear me, listen me, and I don't know if I have some question to answer.
Thank you very much, dear Dr. Jose. It was a very educative and also amazing presentation from you. Thank you very much. And if there is any questions in the chat section, please write it down for Dr. Jose. I know he's a very busy man, and he's also in the shortage of time. So we shall thank again Dr. Jose. And for now, thank you very much, sir. If there is any question in the chat section, in a few minutes, Dr. Jose will answer it for you, and may see you soon in other sessions that will be held in Tehran University of Medical Sciences. Thank you very much, Dr. Jose.
Okay.
Thank you, sir. Thank you
Thank
very
you.
much. And meanwhile, I can see that Dr.
Yes.
Gary Wong here is with
Has
us.
joined us, yes.
Yeah. Dr. Wong, hello,
Hi.
sir. Thank you very much for your time, and it is our pleasure and honor to have you here with us. Thank you very much, sir. We have watched your pre-recorded presentation, and there was too many questions, and fortunately, many of them have been answered by the other participants here in this section. But I can see that there is a very important question, or I can say $1 million question that you have answered here in the chat section. For that, I want to ask you if you can just answer it in person, because it is a question from many of our colleagues here. How can we control the pandemic with the schools open? Can you guide us with that? We do not have your voice, sir. Sorry.
That's good.
Yeah.
Yes. It's a very important question. Now, we must know, as long as there is community transmission, children will get infected. And I must say, in general, I do not worry much about infection in children. I think the role is more continue to spread the infection, as we have seen over the last couple of months, with the reopening and kids going back to school, you see a rapid increase in the number of cases. I think to prevent outbreaks in school, it's more to prevent viruses circulating in children, and the children will bring the virus back home and spread to the vulnerable group. All right. And there are examples in Canada and in the United States, even in nursery, there will be transmission among the kids and spread to the staff. So the strategies to minimize that is, number one, now we have to remember, over half of the infected children are asymptomatic. So it's going to be impossible to screen them when they have symptoms. So practically any child in a school, in a community with transmission, there is a possibility that they get infected. But at least the things that we can do is, children with symptoms, they should not be going to school, and they have to be tested. And as you have seen, the symptoms of COVID in children are so non-specific. There is no way clinically we can differentiate other viral infections versus COVID. And second, and we know the majority of kids get infected because there is a household member with COVID. So any family with an adult infected, the children needs to be screened regardless of whether they have symptoms or not. So that means is any child coming from a home with an infected case, that child needs to be screened negative before allowing going back to school. And the third thing is I talk to a lot of schools. In fact, I don't worry too much about the children. I worry about the teachers, particularly the teachers who are a little bit more senior, as well as those teachers with comorbid condition. They are at risk of developing severe disease. So because of that, if the school can afford it, and there are schools and universities in different parts of the world, they would do this surveillance screening. That is, all teachers are tested every 2 weeks, so as to pick up the asymptomatic infection as early as possible. Now, as you can imagine, in general, in a classroom, the teachers talk a lot more than the children. So it's more likely they produce droplets and scatter around the classroom. So teachers, of course, if they are symptomatic, they need to be tested before they're allowed going back to work. And if we can afford it, a surveillance, every 2-week testing of the teacher, I think would keep the environment in school a little bit safer. And of course, all these measures helps. The third thing is I mentioned about these bubbles. So for example, in primary school, one would cohort the student and do not allow them to mix. Because in case if you have 1 or 2 cases, you can easily quarantine or control that bubble. If you allow the children to mix freely, in recess time, you would run into a bigger problem if there are 1 or 2 infected children. And a lot of children do take their lunch at school. And of course, some societies, they cut back the school instead of a full day of school. They cut it back to a half day so that kids do not take lunch at school, because, lunch is relatively a more dangerous activity because you have to take your mask off and the kids will start chatting and there will be droplets all over the place. So if we can avoid lunch at school, it's nice. If we cannot, the lunch times to be staggered So for example, we would allow the grade 1 to take lunch first in the room. And once they're left, and then we have the grade 2 and then the grade 3. So create this bubble to minimize mixing. So it's some form of social distancing measure to minimize the chance of big outbreak in case, I mean, there are bound to be cases of children infected going to school, particularly those asymptomatic ones. So these would be measures that are possible to minimize the impact of an outbreak at school.
Sir, thank you very much. It was a very nice clarifying of the situation. There's another thing that my colleagues just asked me is that it's a very straightforward question. Do you have any straight protocols that you yourself use for the critically ill child with COVID-19? Can you guide us with that in a short sentence? Thank you very much, sir.
All right. Now, in short, there has not been any useful experimental data, but from the experiences, among the sickest ones, usually they are the multi-inflammatory syndrome. And nowadays, there is no question they should be treated with IVG, possibility steroid. Other than those two, along with all the supportive measures, none of the treatment have been demonstrated clearly in experimental design that is useful. There are some early data suggesting anti-IL-6 receptor antibody may be useful, but the big trial in adult, it was negative. But the case series in children using anti-IL-6 receptor antibody in severe disease, particularly related to the MIS-C, seems to be useful. But I caution about the use of this is because very often case report and case series are very biased. There may be a lot of people out there, they have used anti-IL-6 receptor antibodies and the results are not good. And those reports would never make their way into publication in the public domain. So it would be nice to see an RCT, just like what they've done in adults, in severe pediatric COVID case, and see whether anti-IL-6 receptor antibody works or not. So for now, IVG and steroid, and that's about it, plus supportive treatment.
Okay, so Dr. Wong, just another question that I saw in the chat section about the remdesivir use in these patients. What's your opinion about that?
Yeah, now remdesivir is an antiviral drug that has to be used very early on. Now, in general, the vast majority of children, you're talking about half of them asymptomatic, and among the symptomatic, 80 to 90%, they just have simple URI. And only a very small percentage would develop severe disease. And usually it takes a while before they develop the disease. So when they develop the severe disease, it's too late for remdesivir. So I do not think from the physiology and pathophysiology of the disease as well as the antiviral activity of remdesivir, I think there is a very little role for this drug.
And the last question, sir, do you believe that, in Iran, we are facing a great crisis with the COVID-19 recently. Do you believe that in China, they could control the disease, I believe, or that they claim that they can control the disease? What is the secret point for this China that it could control the disease?
It's not a secret. It's very simple. There are probably 5 things that one needs to do, but these are very drastic things. Now, number 1 is you need to do a lot of testing. That means you pick up the asymptomatic one, you pick up the mild one, you pick up the severe one. I think the major mistake in many of the Western countries is, first, if they are not sick initially, they are not tested. So, and then even those that test positive, they are sent home and they were told to stay at home and quarantine at home. Now, I think the approach in China and in Hong Kong too, we isolate everybody if they are test positive. And basically everybody come in the hospital with any tiny little symptom, or any child in in a household with an infected adult case, you test them all. Once you test them, you isolate them from the rest of the community. Because, how can you quarantine someone who is asymptomatic and tell them, you stay home, don't go around? It's impossible. Try to imagine yourself having the infection. You are asymptomatic. You were told to stay home. You won't stay home, won't you? Because you feel fine. So I think the key is, it's a little bit drastic, because you are isolated someone who apparently is perfectly healthy, but they have a major role of spreading the infection. And so the last thing is, because when you do so many testing, for example, just a few weeks ago in Qingdao, they spent 5 days testing 10 million people. So that means now, of course, there are techniques of doing that. One way is doing what we call so-called pool testing. That means for the general population, if the risks are low, we would take 10 people sample, put it together and test it. If it is positive, then we do the individual testing within that pool. But the majority of these pools will be negative, so that you spend less time doing the testing, and also you spend less resources in doing the testing. So testing isolated all the cases. And you probably have seen some of these videos that you would have actually a big, community hall, a whole bunch of apparently very healthy people doing dancing and things with the nurses. So these are all infected, non-symptomatic or mildly symptomatic. They have to be isolated from the society for at least 7 days, because the shedding of the virus happens very often in the first 7 days. By the time, after a week, you may still be PCR positive, but usually they would not be able to produce an infectious dose to infect other people. So I think that's the key. Do a lot of testing, isolated those who are infected from the rest of the society, and that's the only way to stop the chain. And of all the drugs that are available, seriously, they are not very effective. Even if you look at remdesivir, it doesn't improve mortality. It shortened the hospitalization just a little bit. And then the expensive antibody, I do not see that as a community weapon to reduce severity and reduce transmission. It's impossible. So for now, public health measure, testing, isolation, and hang tight, and give up a little bit of personal freedom.
Thank you very much, sir. It was a very straightforward answer from you, and it was very practical, actually. I hope my colleagues can get ideas from your short speech. It was very, in my opinion, it was very practical, sir. Thank you very much. So, Mariam, is there any questions?
Yes, actually, there's just one last question just asked about the dose and also the type of steroid you recommend in these patients.
Now, there are no trials demonstrating, what would be the optimal dose. And usually for the very severe one would be using a dose similar when we treat intractable or refractory Kawasaki disease. So that you were looking at a very high dose IV methylprednisolone. So not the usual replacement dose. One need to have a high dose. Yes.
Thank you very much, sir. It was very nice answering questions with you, and I'm glad that we could have you with us tonight.
Great. Thank you for having me.
Thank you very much, sir.
Thank
you. I believe it is morning in China, in Hong Kong.
It's like 1:30 in the morning.
1:30 in the morning.
30 in the morning. Yes.
Thank you very much, sir. Thank you very much, sir.
All right.
Have a good night.
Great. Okay. Bye
Bye-bye.
now.
Bye-bye.
Good luck.
Very much.
Yeah.
Goodbye.
Okay. Bye-bye. Bye-bye.
So our last speaker for tonight is going to be Dr. Ali Tawassoli. So I'm going to give you a brief introduction about him. Dr. Tawassoli is a board-certified doctor based at Tehran University of Medical Sciences. He trained in pediatric neurology at the Children's Medical Center and completed irritable white matter disorders fellowship at Children's National Medical Center, Washington, D.C., and Children's Hospital of Philadelphia, USA. So we couldn't have him in person right now. So, but he gave us his recorded lecture. So I'm going to play it for you guys, and you can type your questions in the chat section.
Hello everybody, my name is Dr. Tawassoli, one of the physicians at Children's Medical Center, pediatric neurologist, and thank you so much for scientific and technical supports of Professor Ashrafi and my colleagues, Dr. Aghoy, and other pediatric residents who are working at Children's Medical Center. Thank you very much for providing this opportunity to have a lecture in the 32nd International Congress on Pediatrics. So today my topic is the neurologic manifestation of COVID-19 in children. Let's start with how the virus enters into the CNS. After exposure by the nasal route, the virus enters the olfactory bulb and then moves to the brain and finally settles down in the brainstem area. So it's naturally expected that olfactory nerve bulb dysfunction is one of the clinical manifestations of the infection with COVID-19. And one of the proposed mechanisms for the invasion of the olfactory bulb is the antigen mimicry of the virus with the host cells regarding to ACE2 receptor. And after the virus enters the host cells, its RNAs start to release in the cytoplasm of the host cells and then start to translate and replicate, and finally proteins envelop these RNA and new particles of the virus are released through the blood circulation and distribute over the body. In this picture, for simplicity, you can see after the virus enters the nasal area, there are three ways that the virus can move toward the brain: through cranial nerve 5. As you know, it provides the sense of the cornea. Cranial nerve 1, as I mentioned in the previous slide, as one of the usual pathways that the virus enters the body, and finally cranial nerves 9 and 10, which provide the motor and sense function and bulbar function. So here 4 cranial nerves are shown that can be used by the virus to enter the brain: cranial nerve 5, cranial nerve 1, 9, and 10. What about the distribution of ACE2 receptors throughout the CNS? It's one important point, because whenever of the anatomical parts of the CNS that we have the ACE2 receptor, it can be expected the clinical manifestations that are related to the involved area. In this slide, you can see that we have ACE2 receptor in glial cells, which are the supportive cells of the neurons. So it could be expected that the clinical and imaging manifestations of involved glial cells could be seen in affected patients, including ADEM-like lesions or acute hemorrhagic necrotizing encephalopathy because glial cells are supporting cells for the myelin. So white matter signal change resulting to abnormal imaging finding, and it is secondary to infection with coronavirus. And the other anatomical part of the brain, which is including ACE2 receptors, is spinal neurons. So it's naturally expected that GBS syndrome may be seen and also has been reported as one of the neurologic consequences of COVID-19 infection. So you can see here different anatomic area of the brain have ACE2 receptors, including glial cells and spinal neurons. So we can expect the clinical manifestation of this area in the problem list of the patient. Apart from the ACE2 receptors, we can categorize the mechanism of neurologic damage in affected patients with COVID-19 in three main groups. The first mechanism is a direct neurotropic characteristic of the virus or direct neuroinvasion of the neurons by the virus. And this is similar to enterovirus, as you see. And you can imagine that acute flaccid paralysis due to poliomyelitis or Novak virus have a similar behavior with COVID-19 in this scenario. And the other mechanism that has been proposed as the neurologic damage mechanism in affected patients is secondary to a systemic inflammatory response. You remember that 2 or 3 months after starting the pandemic, a new inflammatory response condition which looked like Kawasaki syndrome was defined as a consequence of COVID-19, and during this systemic inflammatory response we have a breakup of cytokine storm, superactivation of T lymphocyte and macrophage, and also superactivation of the complements. This superactivation of immune systems results in vascular events and prothrombotic events. So post-infectious autoimmune-based effect is the second mechanism that has been defined as a mechanism for neurological damage in affected patients. And the third mechanism is hypoxic brain injury. You know, lung is one of the most important targeted organs which is affected by COVID-19, and hypoxia secondary to severe lung infection is the third mechanism of neurologic damage in affected patients. I have used the term of personalized CNS damage mechanism in this slide because personalized medicine is one of the new emerging medical terms during the last years, and it's important for patients that we provide care and treatment for them, because when we realize the exact mechanism of neurologic damage in each individualized case of COVID-19, we can tailor the specific treatment for that patient. So I use the term of personalized CNS damage mechanism in each patient that we are providing care and treatment for him. Let's move on to the main topic of the lecture and start with the CNS-related complication in children. They are categorized in two main groups, neurological manifestation and psychiatric manifestation. And neurologic manifestation are further subdivided into main categories: central nervous system related complication and peripheral nervous system complications. Let's start with CNS manifestation. Headache is one of the most common reported neurologic symptoms, and dizziness in 28% has been reported. Encephalopathy is the other one, which ranges from an alteration in mental state to a full spectrum on encephalitis, and in severe cases also acute hemorrhagic necrotizing encephalopathy also has been reported as a case report. Viral meningoencephalitis, different type of seizures, including febrile seizures and epilepsy, have been reported as the neurologic consequences of COVID-19 infection. As I mentioned, in the background of immune-based, we have different types of cerebrovascular events such as stroke and subarachnoid hemorrhage. Demyelinating disorders in association with abnormal white matter signal chains in brain MRI are the other consequence of COVID-19. So clinical manifestations that are related to white matter involvement, including ataxia and focal motor neuron impairment, can be expected in the problem list of the clinical manifestations of the patient. Brain stem related symptoms and symptoms of CNS hypoxia are other neurologic consequences of COVID-19 infection. In this picture, at the top left side, you can see two sequences of brain MRI, FLAIR sequences and T2 sequences in a patient with the diagnosis of acute hemorrhagic necrotizing encephalopathy. And you can see a bilateral symmetric thalamic involvement in addition of involvement of globus pallidus and hemorrhage. And this is a severe consequence of neurologic involvement in COVID-19 infection. In the middle of the slide, you see the CT scan of a patient who has presenting with decreased level of consciousness and seizure, and brain CT scan of the patients show subarachnoid hemorrhage in the basilar system area, which are shown by green rows. And finally, at the right side of the slide, you see bilateral white matter signal chains in centrum semioval and the white matters compatible with Adam-like clinical presentation. So a wide spectrum of imaging findings, including hemorrhage, white matter signal chains, and thrombosis and stroke, could be seen in imaging finding of patients who are affected with COVID-19 infection. And this is a very nice picture. I picked up it from one of the papers that has been published in Lancet Neurology just recently as the title of Neurological Associations of COVID-19. And you can see here that the most neurologic consequences of patients who are affected with COVID-19 start from the end of the first week after starting the clinical symptoms toward to the end of the second week. So this is the most probable time that we can expect the neurologic consequences of COVID-19 infection. But please pay attention that this time frame is according to the start of the onset of respiratory symptoms, not related to the time of infection. So it's very important. So just in brief, during the first week or the second week after starting of the respiratory symptoms, we can expect the neurologic consequences of COVID-19 infection. As you can see in this slide, GBS syndrome and encephalitis, one of the earliest neurologic manifestations, but vascular events and post-infectious events are two latest neurologic events of COVID-19 infection. Let's talk about more in detail about the neurologic manifestations of COVID-19 infection. As I mentioned, headache, one of the most common reported symptoms. But on the other side, we have different children who are suffering from different types of headache disorders, including migraine headache or tension headache. So, pandemic of COVID-19 in itself is stressful for these patients. So this stressful event may aggravate their quality of sleep and may aggravate their headaches, increase the frequency of their headache. So it's very important, should be considered in managing of these patients. A febrile seizure is one of the consequences of COVID-19 infection, but pay attention that the incidence of infection is between 7 to 10% of children who present with the clinical manifestation of febrile seizures to emergency department. It's very important. We are not saying that the incidence of febrile seizure is between 7 to 10%. We are saying that the incidence of infection between children who present with febrile seizure to ER departments are between 7 to 10%. It's very important and should be considered. And the other consequence is epilepsy. We talked about the challengeable subjects of patients who are suffering from epilepsy during the COVID-19 epidemic. In this paper, thanks to our colleagues at the Department of Neurology at Children's Medical Center, this paper has been published recently in Journal of Pediatric Epilepsy. And as I mentioned, encephalopathy is one of the other neurology consequences. It's ranged from lethargy, decreased level of consciousness, to a full spectrum of encephalopathy and coma. And what about the neuroimaging finding of COVID-19 infection? As I mentioned, white matter signal change, stroke, thrombosis, and hemorrhage are neuroimaging findings that have been reported in association with COVID-19 infection. But in this schematic picture, I showed the most involved anatomic area in the brain that white matter signal change could be seen in those affected area, including frontal, parietal, and temporal area, corpus callosum and basal ganglia, cerebellum area, pons, and upper cervical spinal cord. Vascular events is also important. It has been reported in 2.5 to 6% of patients, including ischemic or hemorrhagic stroke, subarachnoid hemorrhage as a case report, and also cerebral venous sinus thrombosis. And one of the most proposed mechanisms behind this scenario are the presence of ACE2 receptors in host cells. So it's very important. And finally, one of the most neurologic consequences of COVID-19 infection is different types of demyelinating disorders. You can see here that we have exacerbation of multiple sclerosis in those patients who have been diagnosed with multiple sclerosis previously, new onset of ADEM, optic neuritis, and also transverse myelitis syndrome. And the scenario behind this neurologic manifestation is the molecular mimicry of T cells with myelin basic protein as one of the main protein in the myelin sheath around the nerve cells, and also the presence of COVID-19 antibody in the CSF. So these are two important mechanisms that can explain the presence of demyelinating disorders in COVID-19 infection. In this slide, I have provided a brief report of non-specific CNS symptoms, including acute cerebellar ataxia, brainstem related symptoms, including dysarthria and dysphagia and bulbar dysfunctions. And finally, regarding to EEG findings, we have a diffuse slowing on the background of EEG. Let's move on to the PNS manifestations. I'm sure that most of our colleagues in this conference have heard about the decreased taste as hypogeusia or ageusia in 6% of cases, and also decreased smell as hyposemia or anosmia in 5% of patients as two most common initial presentations in COVID-19 patients. And as I mentioned, due to presence of ACE2 receptor in spinal cord nerve roots, we can expect the presence of GBS as one of the other PNS manifestations of COVID-19 infection. And rarely, Miller-Fisher syndrome with a combination of ataxia, areflexia, and ophthalmoplegia as a variant of GBS is the other PNS manifestation of COVID-19. What about the other uncommon PNS manifestation? It has been reported myalgia and myopathy and proximal muscle weakness, decreased deep tendon reflexes, and interestingly, as I mentioned, acute flaccid paralysis, lookalikes, poliomyelitis, and Novak virus are the other consequence of PNS manifestation of COVID-19 infection. And regarding to laboratory tests, we have an increased level of creatine kinase, but it is more frequently reported in children compared to adult patients. You can see here 57% versus 5% in adult patients. We have increased level of CPK in affected patients. And the final part of neurologic manifestation of patients with COVID-19 infection is psychiatric symptoms. It's a horrible scenario. You can see here a lot of psychiatric symptoms in affected patients. It has been reported sleep disorders, including insomnia and short sleep duration, psychosis, anxiety and feel of fear. Mood disorders include depression and also increased rate of suicide in 20 to 30 patients of adult, especially adult patients who have been affected by COVID-19 infection. Post-traumatic stress related disorders in more than 40% of patients who have been survived an infection of COVID-19 is the other psychiatric consequence of COVID-19 infection. And it is very interesting that the presence of PTSD it's 2 or 3 more times have been seen in affected families who have one case of COVID-19 infection. And finally, delirium is one of the most psychiatric consequences of COVID-19 infection, especially with our colleagues who are working at PICU. And it may be due to sedative strategies that we use in treatment of the patients, prolonged mechanical ventilation, and environmental isolation. So a combination of these factors may explain the presence of delirium in those patients who are admitted in PICU, and it has been reported up to 50% of patients. How we can manage delirium in PICU in these affected patients. In general, there is no drug has been recommended for treatment of delirium, but we can avoid the overuse of potent psychoactive agents such as sedatives or neuromuscular blockers, and the best pharmacologic choice for treatment of delirium are those drugs who do not act through the cytochrome P450, such as citalopram, escitalopram, olanzapine, and sodium valproate. And unfortunately, we have some neurologic consequences that are related to treatment of COVID-19 infection, not directly to the infection with the virus. As you can see here, remdesivir is one of the pharmacologic agents that has been recommended in the treatment guideline of COVID-19 infection, and this drug should not be used in association with carbamazepine, phenytoin, phenobarbital, and primidone because it decreases the level of these drugs in those patients who are treating with these antiepileptic drugs. And ritonavir is the other drug that is used in treatment with COVID-19 infection. And unfortunately, this drug decreases the level of phenytoin and other antiepileptic and also antipsychotic drug. So we should consider this clinical point in treatment of patients. And finally, macrolides as one of the other pharmacologic agents that has been recommended for treatment of COVID-19 infection. And one of the important points is that macrolide can exacerbate the myasthenic syndrome, so it should be considered. And during this challenging time, telemedicine has been one of the best solution to treatment, and continuing to provide care and treatment in those patients who are suffering from different neurologic conditions such as epilepsy and other types of neurologic disorders. And it's very interesting, through the telemedicine we can provide multidisciplinary approach also. It's very important, and the research have shown a similar satisfaction rate and eventual outcome when it is compared with traditional visits. So we can expand the facility of telemedicine to provide a better care and treatment for our patients. And the last slide is the treatment challenge that we have with neurologic patients in the era of COVID-19. One of the drugs that is commonly used for treatment of autoimmune encephalitis, myasthenia gravis, and different types of acquired demyelinating syndrome in pediatric neurology is ACTH, one form of steroid in the form of injection. In these patients, the physician should be careful about the use of ACTH, and they should make a balance between the risk of withholding the steroid in those patients who are treated with ACTH and the risk of worsening of the infection. So it depends on the case. And the other condition is infantile spasm. And you know that we commonly use ACTH as one of the initial steps for treatment of infantile spasm. But it has been recommended that we start the treatment of infantile spasm with vigabatrin and oral steroid, and in those cases who fail to vigabatrin or oral steroid, then we can consider to treat the patient with steroid ACTH. And what about the multiple sclerosis or NMO spectrum disorders? As you know, the biological drugs or immunosuppressive drugs that are used for treatment of MS may exacerbate the infection of COVID-19 infection, but it depends on the case again. And in cases that we have a relapse of MS, we can consider a short-term use of high dose of corticosteroid for treatment of the relapse of the MS. But in general, at the moment, there is no data to recommend to switch the usual treatment of MS patients to another drug. And this is the case in neuromuscular cases. At the moment, there is no current indication for switching or any interruption or changing of drugs in neuromuscular patients who are treating with different types of steroid or immunosuppressive drug. We know that these drugs are associated with the risk of exacerbation of the infection, but we have to review the detail of the history of the patient and also make a balance between the continuing the drug and exacerbation of the infection. Thank you very much for your attention, and with respect to our colleagues and our professors who saved their patients' life, but unfortunately they lost their life. Thank you very much, and good luck for all of you.
Okay, so sorry. Okay, so thank you everyone. So this was the last lecture of today. Thank you so much for staying with us, for joining us, and for a special thank you to all of our dear lecturers and dear guests for joining us despite their busy schedules and for sharing their knowledge with us and also sharing their up-to-date information with us today. So it was really a great lecture for me as a pediatric resident. I really enjoyed this session as the same as the rest of them, but this one with the topic of COVID-19, it was really interesting, and I really thank you everyone for this opportunity. So this was the last session of today. We have the last webinar of Congress will be held tomorrow. It will be about ICU and care of the pediatric sick kids, very sick patients, and we hope to see you there as well. And Dr. Aghaei, if there's anything you can add.
I would like to thank all of our audiences here, especially those who are not from Iran, our friends from region, from Iraq, from Emirates, from Lebanon. I believe the science has no border. We are all here in one region, and we can share our knowledge together, our problems together, and find a solution that can help all of us. So please consider joining us in other sessions and other events, other scientific events. We will share our opportunities with you. So please consider us as your brothers, as your sisters. We are here to share what we have with you. And other audiences that I can see, they are not from the Middle East region. They are all our friends, and we can have and make good memories together. Iran is a country for friendship. Iran is a country that wants to be a friend to every other countries in the world. So please share your knowledge with us, share what we will have together. And thank you very much and have a good night. We will meet you tomorrow for our last session. Thank you very much.
Goodbye, everyone.
Be safe.